Hindi po. Wala talaga nakukuha habang may nagpe-present po. Sa simula. Basta pa after, habang wala pa yung keynote, nakaupo lang talaga. So kahit may nagpo-present siya, nakaupo talaga sila.
First, pag gusto nyo nagkasalita. Yung sa podium sa nagkasalita.
Yung podium nagsasalita. Nakaupo lang talaga sila.
Nakaupo lang talaga sila. Tapos mamaya na pag-question and answer.
Good morning. We will start the program in a few minutes. We appreciate your patience. Thank you.
Sir.
Good morning. We're starting the program in 2 minutes. Thank you. 1 minute more to go. Hi everyone, I am Earl and I am your moderator for our session today. So again, friends, guests and partners in healthcare delivery, good morning. Please greet your seatmates. Good morning, a beautiful morning to all of us. And we look forward to an engaging session. The impact of COVID-19 on healthcare workers has been felt, whether in hospitals, clinics, or in the community. The long-standing problems haunting the human resource for health of the country has been exacerbated by this pandemic. Where do we go from here? What actions do we need to support our healthcare workers? How do we promote retention and resiliency among our healthcare workers? Today, we look forward to hear from our key players and stakeholders concrete steps to address the question, how do we make things better for our healthcare workers today and beyond the COVID-19 pandemic? To officially welcome all of us to our National Policy Dialogue, may we call on the podium the Chancellor of the University of the Philippines, Manila, Professor Dr. Carmencita David Padilla.
Allow me to acknowledge DOH Officer in Charge, Dr. Vergerius joining us in the next hour. Mr. Luis Vinyals Torres, Coordinator of the Health Policy and Service Design, WHO WIPRO, the College of Nursing Dean, Dr. Sheila Bonito, the speakers, the participants, the guests. Good morning. Magandang umaga po sa inyong lahat. It is a pleasure to welcome you to this policy dialogue on supporting frontline health workers' resilience and retention during the pandemic and beyond. I'm not here to give you data because I think when I look at the crowd, you know that the numbers, we don't have the complete set of numbers. Data has been really not complete on a national setting. And it's extremely difficult to come up with concrete policies and implementation programs without understanding the data, not only on a national scale, down to the regional, provincial, in other words, into the granular level. And I think COVID gave us an example that policies on the top will not always just be good down to the ground. So, not unless we have that data, that is going to be our biggest challenge. I'd like to share with you that a few months ago, I participated in the evaluation of physicians. Being a physician myself, I joined a group at the Asian Institute of Management to look at the distribution of physicians across the country, and I'm meaning at the regional level and the provincial level. Even securing the data was a challenge, and analyzing the data was actually the next step. And then coming up with projections is going to be the next step to give to government. We will not be able to say what is needed on the ground unless we have that kind of data. So, what was clear in our exercise is that it cannot be done for physicians alone because the implementation of the health programs in the country and the lowest level involves all professions. So in that particular forum, I actually recommended that we do the same kind of exercise on looking at the national, regional, provincial data for all health professions. Without that accurate information, today's exercise is going to be very difficult. During COVID, we experienced the shortage, but actually, shortage has been here for decades. It's just that COVID pushed the button because it became a reality that we need to do something about it. One thing that I've learned as we were looking at the data is that we do have some health professionals and quite a big percentage who are not practicing their profession. So there's a big challenge on how can we even ask them to come back and practice their profession. And I'm not just talking about physicians, I'm talking about nurses, midwives, and the like. So the shortage is actually a reality, and the dialogue is very important. So allow me to give my insights on the dialogue and moving forward. I actually am I do legislation as a practitioner, and I know that it may be so easy to write a piece of legislation, but the harder part is the implementation. So no matter how brief or how extensive your piece of legislation is, if the implementation is not clear in your mind, then that's going to be a major hurdle down the line. I'd like to believe that policy should be strategic, not only on a national level, but really on a regional and a provincial level, and I said to the smallest unit. When I say that policies must be long term, that's a second element, it's really beyond COVID. It's beyond the crisis of migration. You're talking about long term, not only the next 5 years, but really down the line. So, on the issues of retention and resilience, we're even talking about just how do you retain our health professionals to stay in the Philippines. You cannot talk about resilience without the people. So the third major component that I believe as a practitioner of policy development is it's got to be balanced. And the balancing act is the most difficult part for all of us. When I look at the faces in the audience right now, because some of them are familiar to me and I know that they represent different sectors of the health professions, what exactly is balance? Now, this is my definition of balance. The balance is really when you say that you have enough schools to graduate the students to become midwives or allied health professionals, pharmacists, and so on. That's really just one component of the balance. You may graduate as many physicians, midwives, therapists, pharmacists, and so on. But the second step is how do you retain them? We think that retention is a personal thing. I'd like to disagree. Retention is partly personal, but also partly a national call. When I say it's personal, I may have love of country, and maybe that's why I want to stay. But without the right environment provided by government, how do you expect the people to stay? I always say that in the balance of a policy, the economics cannot be ignored. And when I say economics, because your nurses and your pharmacists and midwives will have to have a certain level of living. And if you do not include the economics of living, then your policy is going to be a failure. So, in other words, retention is just a step. We talk about resilience. I totally support that concept. But how do we get to the stage of resilience? I just want to give since I have nurses, I can see them, and midwives and physicians in the audience. I'm going to give you one example on why people are needed to believe in what they're doing as a test of resilience. As you all know, I run the national program for newborn screening with a coverage of 92% across the country pre-pandemic. When COVID happened, look at that, COVID happened, we got lost, because he said, since we were using the courier service, this program is going to die. A year after COVID, I was surprised to see that after 1 year of COVID, we only reduced from 92% to 80%. What happened? When we checked all the hospitals in the regions in the country, some used the Navy, the military, the police, the firemen to bring the samples from border to border. And the only reason I can say that that program is a test of resilience of a program in the country is that because people in the ground believe it. So if you look at that program now, it's because of people. So if you want a program in the country, we want health reforms right now, then we have to take care of the people who will believe in what we are doing. It's so easy to say it's hopeless, but hopeless is not in my dictionary. People say that it's very challenging and difficult. I say it's also not in my dictionary. Challenge is okay. But there is a solution to everything. So today's dialogue is very important. We have the academe, we have the board examiners, we have representation from government, we have a speaker who can give us insights from other parts of the country, we have the Department of Health, the local government. The first step to success is actually right in this room. But not if we do not move forward together, then it's not going to happen. Today's forum, today's dialogue is a very important step to what we want to achieve in the country. We have the big minds in the room, and I think that we together can really make it happen, but we have to act together. So I'd like to welcome everybody who has spent time to come here, and I hope that after today's dialogue, the next steps will not be forgotten. Because the next steps will be more challenging than the ideas that will come out from today's dialogue. So welcome again, and thank you for joining us in today's dialogue. On behalf of all who want to work for the people and the future Filipinos, let's make it happen today. Maraming salamat po sa inyo and good morning.
Thank you so much, Chancellor Padilla, for the warm welcome and for pointing the value of valuing people at the heart of healthcare. Friends, we are honored this morning to have with us the Coordinator for Health Policy and Service Design of the World Health Organization Western Pacific Regional Office to deliver the keynote message on strategic directions for supporting health workers during the pandemic and beyond. Friends, let us welcome with a warm of applause, Mr. Luis Viñals Torres.
Maraming salamat po and magandang umaga everyone. Thank you very much. Let me first, before I start running the slides and put the slides that we have put together, I want to say that it's very difficult to speak in the Philippines because you are so great speakers. And I don't know why, but the level of speech and the way how the Filipinos communicate is unbeatable, at least in this region. So I always find very difficult to do my presentations in the Philippines. So I like, because that helps me raising the bar. So thank you for your inspiring words. Chancellor has been very, and I took notes because actually we are very aligned on our way of thinking. So thank you very much for coming. My name is, as was said, Luis Viñals. I work near the UP School of Medicine, UP Manila, and also the PGH. So I would like to share a few slides with basically three main areas. Next slide, please. So I think we have to make a reflection on how COVID has affected human resources for health, learning and remembering, because I think that we should not miss this opportunity that COVID has brought to us to raise the HRH issue. The second point I want to make is a bit following a bit Chancellor's words. How we can make health workforce perform, and what are the challenges with a look in the Philippines, and how and what are the more ambitious reforms that we should be looking at from our point of view to make a difference. And finally, just to share, I will not go through extensively, some WHO resources to support on the strategic thinking. Next slide, please. So, as I said, the first COVID has really helped us exposing things that we know, but that we were able to collectively hide. I will, if you allow me, I recall the experience of the country that I was before, which successfully the health authorities were not, that's a bit a contradiction, but this is what I want to mean. Successfully, they were hiding the HRH issues before COVID. This was no longer possible when COVID happened. And let me share that the first reaction that happened when COVID came in, the first cases in March 2020 in the country that I was, it was to rush and start buying equipment, buying ventilators, buying very expensive equipment. But the very first thing that we comment from WHO was, you don't have the people to run these equipments. You want to buy 800 ventilators and you can only operate 140 today. It was an HRH bottleneck. They cannot successfully hide the issue of HRH. So in three lines, what COVID has helped, I would say help, and because I think that's a good thing, has helped exposing. It has helped exposing the issue of shortages, but also skill mix. You know, to run an ICU unit, it's a teamwork. It's not an individual work. So we find problems that you can have the people, but you don't have them in the right mix. So that was exposed. The second was that we were not protecting enough our workers. And the third one is, I don't think that's a big secret, the chronic investment on education and training. And let me put one point here. We cannot fix today's HRH problems in the Philippines because fixing HRH problems takes 10 years. We can only fix the problem, we can start fixing today the problems of 2032. So we have to anticipate what will be the problems in 2032. Do we have the right skill mix that we will need? If we want to shift care outside hospitals in order to have a sustainable system, do we have these people? Next slide. So in WHO, we have had a few rounds of auscultation of our member states to see where the issues were. So one of the things also is not a surprise. What were the biggest barriers of accessing to COVID tools? Because there is the narrative, I think that is quite common, that we had issues on vaccine shortage, on equipment shortage, on PPE shortage. But if we really look at what were the bottlenecks identified, most of the time were health workforce challenges. This was true for diagnostic and testing, for PPE, for therapeutics, and second line for vaccination.
Recording in progress.
So again, at the center of the performance of the system is the HRH issue. Next. As part of the impact of COVID on health workers, there is an analysis, comprehensive analysis done by headquarters where we're looking at 4 dimensions: the availability and distribution, working conditions, health, and social and well-being. Again, health workforces challenge was the major cause for disruption of essential services. Disruption, adaptation, and acceleration of so even production of health workforce was affected by COVID. When it comes to working conditions, attacks to health workers has increased during the pandemic, and also industrial action. So the well-being in the workplace has also been affected. Many strikes because lack of decent working conditions, lack of PPE, etc. So we have issues on the production, being the main driver on the disruption of services, and we have unhappy health workers because they don't feel protected as they deserve. Next slide, please. On the own health of the health workers, we have at least, and I would say that's a very conservative estimation, 115,000 deaths among health workers. And needless to say, stress, burnout, and other mental health issues among our health workers. A stigmatization and the lack of recognition of their own needs as family members, as caregivers also at their place. I think Chancellor brought that point. We are too often not assuming the right things of the health worker. We are assuming that they are bottomless providers of care because of their love to the country, that I'm sure they love their country, or they love to the profession and to love to do a good job with the care, this is enough. From a health authority point of view, from a policy maker's point of view, that cannot be our underlying assumption when we do policy on health workers. Next. So next slide, please. Let me a bit try to stimulate, as following Chancellor Carmencita's words, try to stimulate more effective policy making on HRH in the Philippines. This table or this graph, it's often used by us at WHO when we do labor market analysis. It's a structured way of thinking how we look at HRH in a structured way. So basically, we have policies that are linked to production. We need to train nurses, we need to train midwives, we need to train doctors, etc. So we have to think about policies that allows this function to operate. The second one is policies that helps addressing the inflows and outflows in the market, including there will be migration policies, but also recruitment policies, etc. The third set of policies to look at is the ones that should address maldistribution and inefficiencies. And that, I think I will put a special stress when looking at the Philippines. We want to make sure that the most remote island in the Philippines have access to services. So if you are a citizen, a Filipino citizen, and you are there, you should not be a different access from people living in Cebu. And the last one is policies to regulate the private sector. And I think that's pretty relevant in the Philippines, given the large private sector that we have. So with this way, so we have to act, let's say, on the training and production part of the story, but then we also need to look at the labor market dynamics, how people get into the workplace, how are they being kept motivated, how they are improving their skills, and also when they leave the market or for migration or for retirement or for because they want to go another sector, we need to understand. And let me make a point that Chancellor Carmen Thita was stressing: data. We don't have quality data. And it's not a problem in the Philippines. I'm afraid to recognize that it's a problem regional, and I would say even globally. And collectively, I think that we should all together work on this. Next slide, please. So let me reflect, if you allow me a bit provocatively, about what are the current challenges in the Philippines. Again, you know more than me, the Philippines, you know more than me the challenges. My role here is to stimulate perhaps things to be looked at differently, but you know better than me the challenges. So while we are aiming at progressing towards UHC, because this is our final goal, are health authorities in charge of HRH management? That's a bit my provocative question. What do I mean if we are in charge, of the health authorities are in charge? Most of the decisions that are affecting remuneration or are affecting allocation are done by the market, are done by the market forces. So we as policymakers have difficulties, or we should be playing according to the market rules if we want to affect these outcomes. Because we can complain about undesired outcomes, but if we are not playing by the rules of the market in a sector where the market rules, we might be falling short of our policy goals. For example, remote areas, are we really addressing that? Can we, with the tools that we have, to address that? In a decentralized context, what policy level remains to support central authorities? Let me welcome Office in Charge. Thank you. This is just, again, two provocative questions to make us reflect whether we are using at full the policy levers that we have to meet our policy goals. Next slide. So within the 4 dimensions that I was referring, the 4 functions of the labor market analysis that I was referring, how we could address these current challenges. For example, on the production side, thinking about, as I said, if we are now working to fix the problems of 2032, because HRH takes 10 years to fix that, are we shaping the skills to set the primary healthcare doctors that we might need at that? If we want to shift care outside hospitals, as I said before, do we have these teams? Are we planning today to have these these cadres that will work together to run the primary healthcare system of the future? I think that merits a bit of our collective attention. The second is we have a lot of nurses that goes abroad. There is tools to manage that. There is international cooperation. Is it working? I see a no. Okay, I don't need to be more provocative then. The third dimension, maldistribution and inefficiencies. If most of our sector is ruled by market forces, are we using the financial incentive wisely to address that? Is, for example, field health or IRA allocations addressing the inequities? Let me share an example of my country. A medical doctor in a remote area makes double of the medical doctor, a family doctor in a remote area makes double than what it makes in the city. I know that these solutions, you know these solutions, but are we acknowledging that given that the market forces are the main driver of some of the outcomes that we see on HRH, are we playing enough with these rules to make a difference? And finally, regulation. I think Chancellor Carmen Thita was pointing out at that. It's not the power or the quality of the law. It's our enforcement capacity. Are we really pursuing or getting the most out of this policy lever in order to address the issues, outcomes that we know about the Philippines? So these are just 4 provocative questions to a bit make you feel uncomfortable that we might need to change gears if we want to continue, because there is many good things that has happened. But if we want to accelerate a bit and to reduce the undesirable outcomes that we see in terms of inefficiencies, in terms of inequities, in terms of motivation, in terms of retention that we are seeing in the Philippines. Next, and I will finish soon. So I don't want to go through that. I'm just, because I guess that these slides will be shared by all participants. So I have just put 3 recent WHO products that tries to bring all the state-of-the-art thinking, strategic thinking on HRH. The one is the Global Health and Care Workers Compact. The second is the Working for Health Action Plans 2020-2030, and the Guidelines for Health Workforce Development, Attraction, Recruitment, and Retention in Rural and Remote Areas, which have actually 16 strategic actions that I think are quite inspiring on how we can improve, particularly rural retention. So can we do 3 clicks? More, 1, 2, 3. That's the documents that I'm saying, and then last slide. Maraming salamat po for your attention.
Maraming salamat, Luis. Indeed, we have a powerful opening program this morning. The Chancellor bring us to the context that the policy dialogue should first and foremost address the needs of the people. And of course, that includes our human resource for health. And we are grateful for Luis for pointing that the big challenge is that our dialogue today will bear fruit in 10 years. So there are 3 provocative questions that needs to be answered, and we are honored to have with us this morning brilliant minds, prime movers, partners in the healthcare system to make things happen. So at this point, we would like to start our panel discussion. And may we call on the podium for the first panel discussion on impact of COVID-19 challenges and proposed solutions in supporting and retaining human resources for health during the pandemic. We'd like to call on the officer in charge of the Department of Health, to share her thoughts on the challenges and actions taken to support frontline health workers and future directions during the pandemic. Friends, a big warm of applause for Maria Rosario Clarissa Singh Vergere.
Good morning to all of you. Thank you very much, sir. I will remove my mask. It's voluntary. So we all know it gives us so much hard time, no? Kapag ka nagsasalita tayo with a mask. Yan. So before I start, I'd like to recognize, of course, first Honorable Chancellor Pinchit Padilla, our very good friend. Dr. Kalimag, the President of the Philippine Medical Association. Our very good friend also, Dr. Luis Viñals. We have Dr. Melvin. The President of the Philippine Nurses Association, Dr. Corazon Paras, President of the Integrated Midwives Association of the Philippines, our colleagues from the public sector, national government and local government, distinguished representatives, professional societies, international partners, and attendees of this event. We would like to thank first for holding this significant event that will help shape policies and strategic directions to achieve the goal of supporting human resources for health as one of our pillars of our healthcare system. Actually, nung nag-umpisa po ako na maupo as OIC, one of the very first na ginawa po namin was to meet with Chancellor Padilla. We went to the UP PGH. We went around the hospital, but towards the end, we had a meeting. And one of the discussions during that meeting was healthcare workforce. Because during that time, very evident na yung problema natin, our problems with our healthcare workers. And the Department of Health would like to seek the support of all sectors so that we can address these issues that are confronting us nowadays. So first, towards attaining UHC, all healthcare workers, both frontline and back-end, plays an essential role in ensuring that every Filipino is healthy, protected from health hazards and risks, and has access to affordable, quality, and readily available health services that is suitable for all of our needs. Such reality was further highlighted with our experience with this recent public health emergency, the COVID-19. This exposed long-standing gaps and weaknesses in our healthcare system, most especially our healthcare workforce. Natatandaan ko po, during the time of the pandemic, we were up in arms on how we can be able to deploy sufficient healthcare workers to our local governments, to the different hospitals of the country, to our isolation and quarantine facilities. So we saw how stretched our workforce were during that time because there were a lot of needs that we needed to care for. But also, aside from COVID, we had other non-COVID issues, and that was the issue. And now we are confronted with all of this. Based on our latest data, there is a total of 319,387 practicing in our healthcare facilities in the country. These are all our cadres that are working both in the public and the private. We have 155,496 in our government facilities, and we have 163,891 in the private sector facilities. Of these total human resources for health, nurses have the most share. We have a total of 179,818 nurses working in both government and private facilities. We have a total of 43,616 physicians working in our facilities. The occupational therapist would be the lowest share of our human resources for health, which is just at 169. Last night, I received a call. This call was coming from a hospital in the country, and they were saying they are losing people, especially their psychologists. So this is just an example of how irrational maybe, or that our workforce strategy should be better directed. So they have these psychologists in their hospitals, and these psychologists, they have to serve as psychometricians in our hospitals. For you to be qualified as a psychometrician, you need to take additional years of study in order for you to be a psychometrician in the hospital. If you enter into or be hired as a psychologist in a hospital, your grade level is the same as a grade level of a driver. Grade 6, that's the plantilla level. But if you become a psychometrician, your grade level or the salary level of a psychometrician increases, and it's around salary grade 9. So they were saying they were losing their psychologist because the psychologist doesn't like to anymore have another 4 years of study and become psychometricians, when in fact they're done with their psychologist course. So they were asking, why is it that when they were asking DBM for additional plantilla, the DBM said, DOH, we cannot approve this request because DOH doesn't have the psychometricians and the psychologists as part of the pool of workforce in the country and as part of the certified list of DOH. So this is just one example of how the strategies that we have right now for healthcare workforce in the country is so much lacking that we are neglecting to include those professions which are part of our healthcare workforce, that they be included and be part of the pool and the list of our healthcare system to be included, that they can also have that opportunity to have this career growth and the professional development, and of course, be paid with appropriate salaries based on their task. So just an example of that, and we saw this kind of issues throughout this pandemic, and now more than ever because, pandemic, we have shifted our mind away from the pandemic. We are seeing it more and more. During the time of the pandemic and up until now, a lot of hospitals closed, and maybe Dr. Kalimag can attest to that. And the primary reason why hospital closed would be the lack of manpower. We have standards of care that we implement based on our licensing standards, and these are very minimum standards. When you are in regulation, it's hard to be flexible. That when the hospital says, tama na yung dalawa kasi 4 ang kailangan, we cannot do that because if something happens, it's going to be the accountability of the Ministry of Health. So we need to impose this kind of standards, this kind of regulatory standards, and unfortunately, the big hospitals, of course, can always comply. But the smaller hospitals, they were the ones left to close during this time of the pandemic because most of our healthcare workers migrated, or most of our healthcare workers got burnt out and they didn't want anything to do with health for this time being. So just recounting to you the different challenges that we face right now with our healthcare workforce. Moreover, we have seen challenges also like there would be long working hours because kakaunti na lang healthcare workers. Some of them got quarantined, isolated. So some of the healthcare workers have to cover for their mga colleagues that had been in quarantine. They have limited accessibility to the requirements of occupational safety and health. Maybe we can find these requirements in higher level facilities, but when you get to go to these areas which are really far-flung and smaller areas, you'd find the status of our healthcare workers then. Just recently, I went to Maguindanao. I went to this Buluan District Hospital. It's supposed to be an infirmary, but because it is the only hospital and kilometers away by the next higher level facility, they were admitting patients, and the patients were all in corridors because they are so cramped. And you can see our healthcare workers stretched to the limit because their capacity is just this much, and they have admitted because walang magagawa this number of patients. And just imagine that these healthcare workers would be giving long hours of work because of this more than the bed capacity of the hospital that they cater to. So this is part of what our healthcare workers are faced day in and day out in their line of work. There is this absence of health insurance. I don't know for the private sector, but in our public health sector, we have the PhilHealth, of course. But after that, they don't have any. So during the time of the pandemic, it was mandated that our hospitals should be able to cater to the medical needs of our healthcare workers for free. So all of those who have had COVID, they were admitted in our hospitals and they were given the service for free. Even up to now, in our government facilities, we still admit our COVID-19 patients or healthcare workers, even though they don't have symptoms, even though they have milder symptoms. Why? Because it is our courtesy to our healthcare workers that we care for them when they are sick. Now, here comes the problem. When we were having increased cases during the time this July and August also of this year, we needed the hospital beds. So when we tried analyzing, most of those that are admitted in our hospitals were our healthcare workers who are having mild or no symptoms at all, but they had to be monitored because they had comorbidities, because they have this previous experience with COVID. So we had to find a place so that we can transfer them, so that we can make the beds available to our patients. So this is kind of a dilemma, but that is our scenario and situation right now. There is also violence and physical harassment among our healthcare workers. If you remember, during the first few months of the pandemic, our healthcare workers were stigmatized for working in hospitals with COVID-19 cases. Some of those, I think that was in Mindanao, they were even harassed and they were even, tinapunan sila ng some kind of chemical so that they can be disinfected. But that was really harassment. And the discrimination was really high during that time because we were caring for COVID-19 and the community was, of course, kind of scared, but they were really discriminated. So all of these things add up, and this is the situation that we have right now. To realize universal health care and to realize the resilience of our country and our healthcare workforce in these times of the pandemic or public health emergencies, building institutional capacities is critical. Additionally, in order to address healthcare system gaps, intersectoral collaboration must be strengthened, and plans and policies must ensure needs-based production and retention of our human resources for health. We need to identify which cadres are lacking and focus on producing on our own the needed healthcare workforce, ensuring an adequate number of healthcare workers in our country. This would be done through scholarship programs. We hope to send a total of 300 scholars, masteral and PhDs in health to top universities globally. So every day, may mga schedule po kami na mga ambassadors coming from different countries and the other top officials of development partners. And we are now telling them of this exchange program and these scholarships that we would want for our people. We are going to identify 300 qualified all over the country. It doesn't matter, you're a doctor, a nurse, a midwife, as long as you are qualified with the criteria, we are sending you out abroad to top universities globally so that we can produce our own cadre for us to implement properly universal health care and the Center for Disease Control. This would be a target for us until the end of this administration. We are already working on with CHED on this. They have the CHED Fulbright Scholarship Program, and we hope we can still expand. Of course, we are working with Dr. Padilla regarding this matter as well, and also with the top universities of the country. And as I've said, what would be most important would be our bilateral agreements with other countries so that we can send our scholars to their top universities and eventually they go back to us and we spread them to the sector. Also, to support health reforms, we are looking at strategic partnerships with institutions. Katulad po ng sabi ko, we have discussed already with Chancellor Padilla how we want to continue our health policy fellowships and internship program. Meron po kami dati na health fellowship and internship in our institution, the Department of Health. We were able to hire 50 during that time. And you know what? These 50, maybe around 40 of them are now working across the different areas in the healthcare system. It is not just in government. Some are in PhilHealth, some are in the private sector, some are with development partners, pero marami sa kanila, most of them are with us in DOH. And most of them right now, because they are qualified and had been trained effectively, they are now officials of the department, directors. We already have an assistant secretary who was once a fellow undergoing this kind of trainings with the UP Manila and also the other institutions. We also have this stepladder program as introduced to us by Chancellor Padilla, and this we would want to pursue. This stepladder program is something of a more flexible arrangement with our healthcare workers. So what UP Manila does, they send out for scholarship. Maybe they have scholarships for midwives. Then they let them go back to the community. After they immerse again in the community, if they want to take up medicine, for example, again, UP takes them back. And we want to adopt this so that we can also be partners with our local governments for whoever would want to have this kind of program, the stepladder program. We will be investing in this. During the time that Dr. Kalimag and I and our teams went to Pampanga, we went to an area, the indigenous people there in Pampanga. There were two students, pre-med ba, Doctora? Or doctors already? They're taking up nursing. So we are starting to identify students from our area, especially those far-flung, who can be able to, or who are very much interested to take up these healthcare courses. We will invest in them, then they go back to their communities. It's quite hard for us to encourage people to go out and go to our far-flung areas. We need those people who really are coming from there so that there is commitment, the passion to serve, at saka yung malasakit nila sa kanilang mga kababayan. And that is something that we are already doing right now. To be able to address the gaps in our healthcare workforce, the Department of Health continues to bolster its investments in our human resources. We already have our health sector strategy 2023 to 2028 as we recognize the importance of our healthcare workforce, where we want our healthcare workers adequate, committed, they are fairly compensated, given opportunities for professional development in healthy working environments. And to realize this, we all need to work together to implement this National Human Resources for Health Master Plan. This sets the roadmap for us to fortify our partnerships and collaborations with different agencies and institutions to strengthen our human resources for health. We will continue to strengthen our policies and strategies for the appropriate generation, recruitment, retraining, regulation, retention, and reassessment of the healthcare workforce based on population health needs. I think what would be most important to remember in this statement would be it is based on the needs of the population. In the past, we used to produce a lot. Remember the time when the nursing schools were closed because we were producing, but the need is not there. So it has to be a balance of supply and demand. So right now, we are trying to identify the different cadres that are badly needed across the different areas, facilities of our country so that we will know which cadres or professions we need to produce immediately and which cadres can wait a little longer that we will produce in the medium term. So this is something that we are trying to focus on right now so that we will know the exact needs of our population. Moreover, the DOH continues to bring primary care closer to our people. To date, we already have 207 primary care facilities in the Philippines located in different regions. This caters to the immediate needs of our communities. Unfortunately, among these primary care facilities, 98% are from the public sector. Only 1.9% are owned by the private sector. And we think it is just a misconception that when it's primary care, it's the public sector, which we should remove from our minds. It should be that both the public and the private sector work towards the objectives of primary care. So now we are opening our certification process to our private sector, their outpatient clinics, their clinics at home, whatever clinics, as long as the primary care physician can be certified by the Department of Health. I even told the specialists during one time that we had this session with Dr. Kalimag and the societies, even specialists can become a primary care provider as long as the qualifications are there. So it is open. It should be worked on by both the public and the private sector. We have a target of around 120,000 primary care facilities by 2040. And hopefully, with the help of all of us here and the help of the private sector as well, we will be able to achieve that. Our goal is to expand all of this to our regions. Every locality should have a primary care facility. It is in this light that we underscore the need for more human resources for health. Kaya po, nung isang beses, kami po ni Chancellor Padilla attended a commencement exercise. And this was an exercise, the graduation of public health students. And that was an auditorium where we had it. Kalahati lang po yung tao. So sabi ko kay Chansey, pwede po ba by next year or maybe in 2 years' time, puno na itong auditorium na to with public health professionals graduating and having this course. One of the, I don't know, no? But this is the situation in our country, that public health is always, parang, it's not neglected, but the interest of our students are very low. I was telling Chancellor when I was having my medical training, never did we hear any of our DOH programs in our curriculum. Never did we hear that any of our professors would encourage us to go into public health. It would really just be your, I don't know if it was intuition, because my father was some kind of politician in our area. So when I graduated medicine, he asked me, do you want to work here? And I immediately said yes, without knowing what I am up to. So I was immediately hired and placed in a rural health unit with a 180,000 population. So I stayed there for 11 years and I saw how it was on the ground. So, I mean, if I was in medical school and nobody was telling me or giving me that orientation or that push for me to take up public health, nobody's going to do that for us. And I was asking Chancellor, can we have a program for this so that we can better encourage our students to take up public health? And Chancellor Padilla said and readily agreed. So on Saturday, she already had done it. And after just, I think, 2 months, meron na siyang sagot sa atin. We already have a meeting. And we will be meeting with the different deans of the University of the Philippine system. And we will start to do this to better encourage our students to get into public health. So to ensure retention and mobilization of our healthcare workforce, the Department of Health continues to put forward measures to support the welfare, the growth, and development of our healthcare workforce. We have developed mental health standards programs to support initiatives specially targeted towards healthcare workforce to ensure their mental well-being. We have granted this very controversial mandatory continuing benefits and allowances to our public and private healthcare workforce during this time of the pandemic and other future public health emergencies. We have our health emergency allowance for every month of service according to risk classification. We also have sick and death compensation benefits in the line of duty for our healthcare workforce if they get sick of COVID or die from COVID. We have full health coverage for direct healthcare costs and hospitalized care for non-healthcare workers and healthcare workforce due to COVID, and the regular testing of our healthcare workforce. Further, we have different programs, and just to very fast, the nurse certification program, initiated and supervised system of strengthening and certifying competencies of nurses based on a set of standard competencies in 14 specialty areas. The leadership development course for public health nurses. So we've started with this already. This is a 40 continuing professional development unit postgraduate offered by UP Manila College of Nursing to all our public health nurses and our nurses from our regional offices and central office. We also have in-service postgraduate scholarship programs which provide opportunities to human resources for health to enhance their competencies through formal education. We have exchange programs for our specialists. Alam niyo po yung inadequacy in the number of our specialists in different areas in the country. Let's say, for example, in Batanes, we tried assessing the situation, sat down also with Congressman Gato. In Batanes, they have a level 2 hospital. But in Batanes, they don't have anesthesiologists. They don't have any of the other specialists. They only have ENT, who is Congressman Gato. And then I think they have one surgeon and one obstetrician and one pediatrician. The rest, none. So every time there are cases, medical conditions that are affecting the population in Batanes, they had to fly them out and bring them to a facility, maybe in Baguio, whichever is nearer and less expensive. And Congressman Gato was saying he spends around 50,000 pesos just for one patient to be transported out of Batanes. And just imagine the cases. There was once he was saying, napuwing. You know napuwing, Luis? You have something in your eyes and then it gets infected. So napuwing, no? So they had to transport the patient out of Batanes and had it treated in another facility, which cost too much. Remember, even though local government spends for that, or even the patients, it is still a cost incurred for health. And it is a burden to our economy. So just imagine po, yung mga ganito, these are the situations that we have right now. So what we did, we have exchange programs for our specialists. We discussed with our hospitals, and now East Avenue Medical Center is already providing this specialist. No? So there is every 2 weeks duty going to Batanes. But we all know that this would be temporary. We cannot sustain this for long. We need to develop their own. Which brings me to our program. Thank you, Luis. Thank you. Which brings me to our program where we would want that we are purposively producing our own. That we know what we need and we will be producing them. So this is one of the programs of the department. And alam nyo po lahat, the multi-specialty centers that we have across the country, which we are pushing right now and is part of the directions of the current administration. I'd been to Mindanao, I'd been to the North, I'd been everywhere, to Bicol. Ngayon ko lang nalaman din na ang gagaling because we were already conducting open heart surgery in Mindanao. Also in Bicol, also in the North, these multi-specialty centers are already functional. And it is quite, how do you say that, encouraging that eventually our Filipinos will have better access to better health care. And this time around, what we are doing are exchanging programs for specialists. Our specialists from the Heart Center, the doctors from Mindanao, for example, from Cotabato Regional, will go to Heart Center. They will train there for a number of months. Then they go back to their place to do the procedure. That is also what's happening with NKTI, with Lung Center, and the different areas. Even in our National Center for Mental Health, for Psychiatry, we already have that program. We also have the Primary Care Worker Certification Program, which I have mentioned to all of you. We have legislative measures. Ang dami ko sinasabi. Please forgive me, I only have 2 pages to go. But I just like to tell all of you that we have submitted a proposal, a bill, to amend the Magna Carta for public health workers, where both public and private should receive Magna Carta benefits. We also have submitted the standardization of salaries between public and private healthcare workers. We also have submitted upgrading of our hospitals to improve service delivery. And that would mean that we can be able to hire more of our healthcare workers because we are expanding our capacities in our hospitals. So I will not read everything. I just wanted to tell all of you of these different measures that the department is currently undertaking. And we have already tried to assess the situation of our healthcare workforce. We have the numbers. We would just want to identify which really would be the most immediate that we can work on in these next 3 years, and what can be long-term in this until the end of the administration. Please be assured that the department is here working with all of you, and we hope also that all of you will work with us so that we can be able to address the different issues confronting our healthcare workforce currently. So with that, I'd like to thank all of you. Again, thank you to the organizers. I think this is a very critical activity that needs to be expanded and furthered on. We need to do this policy discussions, Luis, and have this in other areas as well, so that we can be able to try to identify solutions to our current problems. So with that, maraming salamat po. Sana po lahat tayo magkaisa para sa healthy Pilipinas.
Maraming salamat po, Dr. Vergeire, for the assurance that the DOH is doing its job in making universal healthcare possible and supporting our healthcare workers this critical time of the pandemic. And hopefully, we can cascade these efforts of dialogue across the regions and other areas. So maraming salamat po, Yusik Vergeire. At this point, let's now listen to our second panelist to share his insights on the impact of COVID-19 among physicians and innovative strategies for their retention. Friends, let us welcome the President of the Philippine Medical Association, Professor Dr. Maria Minerva Kalimag.
Magandang umaga po sa inyong lahat. Hindi ko alam kung nasaan yung Just like to say that for our present workforce, there are again 3,800, ganyan. Nakalimutan ko po yung salamin ko, sorry. Lalabas lang po ng physician licensure examination. A few hours ago, 3,826 already been added to our workforce. And what am I going to say? What is the impact? Ayan, okay. So, the impact of COVID-19 among physicians. Feel ko po ito, no? I felt the burden of COVID-19 personally. Why? Because I have 8 physicians, 7 physicians actually, and 1 physician to be in the family. They have gone through all of this So, as I've said, 7 of them are already full-fledged physician as of last night. And they have gone through all of these mental health issues. The hardest hit was actually the 2020 batch, no? Because their internship was cut short on April 2020. And what happened was they had to go through a long process of studying for the boards, thinking that the boards will come in September of that year, 2020, and it was pushed back to November 2020. And then they got the results of the boards last week of November, and all of a sudden, they have to be plunged into residency training. The batch of 2020 that took the boards in November 2020 had the highest rate of attrition. They enter into residency training programs and they drop out. And if you will look at the records, the main problem was mental health issues. Diba? So one of them, of course, the problem was women are almost 70% of the global health and social workforce. But it is estimated that they only hold 25% of senior roles. We still have the glass ceiling, no? And during the COVID-19 pandemic, women have provided much of the health care, but have not had any equal say in decision making. So this is a leadership gap that can be gleaned, no? And this is a systemic barrier to women's advancement. So this is my daughter just recently passed the physician licensure exam. So the policy action paper that outlines the framework for change across 4 action areas, this is the policy paper in June 2021, which states that we have to build a legal foundation for equality in the workplace, address social norms and stereotypes, address workplace systems and cultures, and enable women who are in the majority of the health and social care workforce to lead. No? I think this is more of a global issue rather than an issue in the Philippines, because in the Philippines, women lead, right? In fact, if you are in many of the national medical associations, for example, in the Philippines, the Philippine Medical Association have 7 out of its 97 past presidents, no, actually who have led, women leading. In Malaysia, for example, there's only one woman past president of the Malaysian national organization, the Malaysian Association of Physicians. Actually, only one, Mary Cardosa, who is a female, an anesthesiologist. And in Thailand, there is only one also leading, no? Somsri Pausawasdi, who is now head of the Medical Council of Thailand, also an anesthesiologist. So what we lack behind the screen, no? We make up for leading health organizations. So about 115,500 health workers globally, a conservative estimate, is believed to have died during the pandemic. No? And of course, this is due to later on, we push for better access to personal protective equipment, and of course, COVID-19 vaccination. Later on, I'll show that what the Department of Health is, of course, doing right now. No? Now, I remember that one of my sons, no, who is into cardiology, meron siyang baby. He cannot go home for the first few months during the COVID pandemic. He has to, sacrifice because of the fear that the baby will have the COVID. So this is one of those things. And of course, he said, I only eat once a day. before I enter the ICU because I don't want to change PPEs every time I go out and eat. So those are things that they go through, no, during the COVID pandemic. Of course, there is work time and workload, lack of recognition, no, including inadequate pay and support services. Of course, we know that meron tayong health emergency allowance. When I speak to some, sabi nila, nag-ano sila, doktora, yung risk assessment. Sabi nila, hindi naman nangangahulugan kasi when you go to the hospital, you're definitely exposed already. So, bakit daw meron yung risk assessment? No? So, papakita ko din yan later. Pero, yun nga, no? The first of the daughter that is in the United States was not assigned to a COVID facility. Pero siya yung unang nagkaroon ng COVID doon. No? So, yun nga, kasi because I think sa totoong ano ng tao, no? When people think that they will be discriminated upon when they go to the COVID ward, they'd rather go to the non-COVID ward first to have themselves diagnosed, diba? And seek help. So, again, prolonged use of PPE and PPE fit, no? Harassment, violence, stigma, and discrimination have been discussed. Mental health, including, ang sabi nila, they call it cabin fever. They're suffering daw from cabin fever. No? And then, of course, sanitation and hygiene. So, the purpose, of course, of workplace risk assessment is to determine the level of risk for occupational exposure related to different roles, work tasks, and work settings. Plan and implement adequate measures for risk prevention and mitigation, and assess individual health workers' fitness for work and return to work, including workers with comorbidities. So this is the risk criteria. No? Here are the risk criteria. And while it is true that those assigned to high-risk areas do get infected first, no? It doesn't mean that patients working in less infectious areas cannot be infected, no? So there's a need to organize work time and workload for healthy and safe work environment, no? So they may be working long hours with heavy workloads and insufficient time for rest and recuperation. So this can result in chronic fatigue and lack of energy with decreased alertness, coordination and efficiency, and increased reaction time with impaired cognition and mood changes. So, this is actually one of the reasons why some do not want to go into government practice. No? They fear that because of the long hours and the heavy workload, no? Like at East Avenue, for example, our anesthesia would have 27 cases in the morning and another 17 cases at night. So talagang they're working overtime. So these are things that we have to consider also. I'm sure at UPPGH it's even more, but you have more, I think, Pantili items as well. So we should, of course, provide enough available staff, including additional recruitment with flexible working hours, distribute workload, tasks, and roles fairly, and ensure longer working hours are actually temporary and that rest periods are available. So, gusto ko ring bigyan pansin, no? USEC actually mentioned something about lateral entries I think that is one of the best strategies that we can have. And what is this? Actually, we have, for example, at East Avenue Medical Center, we actually trained, for example, anesthesiologists with plantilla items coming from the mountain province, and then they train at East Avenue, and then they go back. So when there are operations or patients for operation, they are anesthesiologists. But then when there are no patients for surgery, then he works as a public health physician. So so the roles are flexible. Tama yung sinabi kanina, as whether a specialist or a public health practitioner is a role that you play. It's not a title that you have, no? We have also anesthesiologist coming from Kalinga Apayao, who was president of the Apayao Medical Society, an anesthesiologist coming from East Avenue, and another one in Kalinga. And then we have an anesthesiologist trained who went to Amay Pakpak in Lanao del Sur, in Marawi. And as I was chair of the program accreditation, sabi ko, bigyan na natin ng accreditation ng Amay Pakpak because they need to have trained anesthesiologists because their surgeries and OBs are already being trained and in accredited training programs. And maganda because now they're on their third year, no? And many of them will be graduating next year. So these are things that we look into. We used to have a PMA governor from Lanao del Sur. Sabi niya, Doktora Kalimag, padala ka naman ng anesthesiologist sa Lanao del Sur. Sabi ko, sasabihin ko palang Lanao del Sur. Ayaw na nila, no? So I said, talk to your LGU, your governor, and tell him, give you a plantilla item for somebody who's staying there in Lanao del Norte, so that he or she will come back to you. No? I've been to Tawi-Tawi, and there are doctors to the barrios there. Sabi ko sa kanila, why don't you train in Manila and then come back? Anyway, you know the terrain already. No? So, but they have to go to another island and cross, no, to the other island by boat. So, sabi ko, you know the terrain already, so you better train in Manila and then come back here in Tawi-Tawi, no? So here is about lack of recognition, including inadequate pay and overtime, which can impact health workers, including resulting in departures from service. Pero I'll tell you that even if, for example, we're paying them high in government service, some would rather work in private institutions even for a lower pay, because they fear that there's so much work in government. So here, PPE is intended to be used for short periods of time, but like this one is an OR setting, no? But for example, for the ICU, they have to wear it for prolonged periods of time. So in the context of COVID-19, heavy workloads and patient flows may require health workers to wear PPEs for extended periods of time. So if used for a long period of time, they can cause, of course, all the skin manifestations, no? Sweating inside your PPE. So, advice for healthcare workers on safe use of PPE: use non-latex or nitrile gloves in case of latex allergy. Use properly fitted PPE. No, limit time spent in full PPE and rest in a cool area. Like this one is a pathologist, no, at NKTI. So he'll need to wear the full PPE for as long as he's there, no, on duty. Should drink enough safe drinking water and avoid using coveralls, double layering of gowns, shoe protection, or hoods, no. So these are some of the contact dermatitis that happens due to excessive use of mask, no? So, and then, of course, violence, harassment, stigma, and discrimination. I think this is something that we should address because this is a culture thing. This is the culture of hierarchy in our institutions, no? And the harassment can be verbal, written, physical, or visual. And I've always, for example, surgical specialties, they are the ones most prone. I don't know, perhaps we should address this, Chancellor, no? Because sometimes with social media, naka-Viber group sila, and then they will be castigated, no? With everybody knowing about it. So I think this is something that we have to have policies on, no? And then so we can also report, no, incidents of harassment, stigma, and discrimination. The president of the World Medical Association, President Dr. Osahon and Abulele, warns about being burned out, no, during among junior doctors. So yeah, no. So it's not just in the Philippines; it's happening all over. So yeah, he calls for revitalization and strengthening of mentorship programs. So I think mentorship programs is one thing that we should address, as well as improved working conditions, career development, continuous professional development, and effective communication. So I assured them of the WMA's commitment to their well-being and career development, and finally assured junior doctors around the world of WMA's commitment to address global rise in violence against physicians in their workplaces. So, mental health and psychological support for health workers. So, recommendations to protect mental health in the workplace ensure that accurate information updates are provided to all health workers, rotate workers from higher stress to lower stress functions if possible, partner experienced workers with inexperienced workers with experienced colleagues, and provide mechanisms for early and confidential identification and management of anxiety, depression, and other mental health conditions. To initiate first-line interventions. At the PMA, we have asked Philippine Psychiatric Association to provide support, no, for the mental health of our healthcare professionals. And but they have a problem. There are only about 300 of them all over the Philippines. And it's a good thing that, well, we have telemedicine and that psychiatric evaluations can be delivered via telemedicine. So we promote a mental health prevention culture among health workers and health managers. At UST, we have a PCHRD grant for addressing depression, anxiety among students in higher education, because we have socio-emotional learning programs for undergraduate, for the elementary children, no? But we do not have one for higher education. So that is something that we will address as well. So we ensure access to confidential mental health and psychological support services, train health workers in basic psychosocial skills, and ensure that health workers who develop mental health conditions can seek help and return to their work without stigma or discrimination. So these are for adequate sanitation, hygiene, and rest facilities, of course, for health workers, no? So yeah. So this is the steering committee for the 2021 International Year of Health and Care Workers issued a joint statement on for immediate and concrete action to protect health and care workers, to strengthen data collection and reporting on infections, ill health, and deaths among health and care workers due to COVID-19, protect health and care workers during and beyond the current global COVID-19 pandemic, and accelerate the vaccination of healthcare workers in all countries. So, at the DOH, of course, we have the National Booster Vaccination Days, the Bakunahang Bayan, September 26 to 30, and then to include the senior citizens, October 1 to October 7. No? So, we have the Pinas Lakas program. So, I think the Department of Health knows that the Philippine Medical Association did its part. No? The Philippine Medical Association consists of 91,030 physicians, of which they are in 116 component societies all over the Philippines, 75 specialty and subspecialty societies, and 45 affiliate societies. The affiliate societies are the ones bonded by advocacy. No? So, as a whole, the Philippine Medical Association is a very big coalition of healthcare professionals. And we are working with government, we're working with the Department of Health to ensure that our vaccination programs are in place. So, much of the concern for the universal health care, and this is something that I'm trying to allay, the fears that the specialists will be sidelined because of universal health care. And I always tell them that being a primary care physician is not just for public health or public physicians. No? That actually, the specialists will even have more cases because they will be able, the primary care physicians will be able to see or to detect patients with pre-diabetes, for example, with before they even get worse. So I told them, you don't have to worry, no, because people will line up, patients will line up for the specialist after they've seen the primary care physician. So I hope that we can address all of these issues regarding our physicians, and I'm looking forward to better post-COVID conditions. Thank you very much.
Thank you so much, Dr. Kalimag, for sharing the plight of our physicians and what programs have been undertaken by the Philippine Medical Association to address the issues of our physicians in the light of the COVID-19 pandemic and beyond. Now, at this point, we would like to inform our friends, colleagues currently on site that we also have our colleagues joining us via Zoom and Facebook Live. We have hundreds joining us, and they already have pressing questions on the chat box that we will share later during our open forum. And we hope our panelists can address some of their queries. So at this point, I have the honor to introduce our next panelist to share his insights on the challenges and proposed solutions in retaining this time our nurses in the workforce. Friends, a warm of applause for the President of the Philippine Nurses Association, Dean Melvin Miranda. Yes.
Thank you very much to our distinguished guests from the University of the Philippines and to the College of Nursing, to the Department of Health, OIC Berhere, and to the representatives of the various sectors and professional organizations. Good morning to everyone. We have been recognized in various endeavors where nurses really participated in most of the initiatives of the government pertaining to our response to the COVID-19 in the last 2 years. We are working hand in hand with the other professions, with the doctors, and with the other allied health personnel. Nurses had been recognized even with the International Council of Nurses, where the Philippine Nurses Association have been a member, and we are advocating for the investment or investing in nurses and protection of rights of our nurses to secure global health. This morning, I was requested to have a talk or share insights and experiences pertaining to the challenges and proposed solutions in retaining nurses in the workforce. Just recently, the International Council of Nurses have engaged into the strong partnership with the World Health Professions Alliance and with the International Council of Nurses to attend to some challenges and issues pertaining to the nursing profession. And this is indeed a collaborative effort, not just only with the international organizations such as the ICN, but also with other professional organizations of the other professions. And with the last 2 years of the pandemic, our nurses across the regions and areas of the country have actively participated in various endeavors, such as it gave us the opportunities to explore and expand our roles when it comes to career advancement. And in fact, nurses have been engaged into the various professional development and endeavors on advanced infection prevention and control management across the healthcare delivery system, from the promotive up to the rehabilitative phase of the delivery system. And this opened also the opportunity for the nurses to explore on various skills training so that it will upgrade our competencies. Simply, we have the oath of responsibility to serve our people in spite of our fears and anxieties. However, with these hesitancies, it's in our heart and in our mind that we have the compassion and we have the caring attitude that we pursue these endeavors in spite of these challenges. Other than that, since we have been exposed to public health, nurses have been tapped and have partnered on how we will consider the promotion and prevention in our communities, wherein we have the advanced epidemiological investigation and research, wherein most of the findings that we have considered in the nursing profession have been used, particularly in the various policies and guidelines in the national level and even in the local government units. Other than that, this is one of the major concerns wherein most of our institutions have encountered in the past 2 years and even at present, the human health resource management. So in spite of the scarcity, in spite of the shortage that we are saying in some of the news, still most of our healthcare institutions in the country still manage with the trained and competent chief nursing officers to manage on how we will still consider our nursing workforce as the front line of every healthcare institutions in the country. And indeed, with this transition of our situation or healthcare situation in the country, we have been involved in the nursing and health informatics. Even though during the pre-pandemic, this has been introduced in our profession, but it was strengthened. So as mentioned po by our PMA president, it has emphasized the teleconsultation, the telemedicine, but moreover also our nurses have been engaged also in the trainings on how we will consider the emphasis of the health informatics and nursing in the system in spite of those situations that we encountered in the last 2 years. On the local and the national issues, we have considered a concern with the demand and supply. Even our OIC have mentioned that we lack 106,000 nurses in the country. And with this endeavor, we have considered the United Nations ratio of for every 10,000 population, we need 28 rather, nurses. So with this ratio and with the standards, we gear towards on how we will take into consideration our realization to provide solutions. Because there are lots of opportunities that are being offered to our Filipino nurses. We are aware that even foreign and overseas recruitment agencies are here in the country because they believe in the competencies of our nurses. We are very competitive when it comes to the competencies. So that's why they have considered our Filipino nurses. However, we must also take into balance on how we will have the solution to retain our nurses in the country. So that's why even the Department of Health, in coordination with the various government agencies, as well as with the accredited professional organizations, such as the Philippine Nurses Association, have opened opportunities and dialogues on how we will attend to this. Number two concerns wherein it opened also opportunities for us to explore is on the welfare concerns of the compensation and benefits. Through our coordination with the Private Sector Advisory Council, our strong communication have geared towards on how we will communicate and coordinate with various healthcare agencies or government agencies to provide short-term and long-term solutions. And this is definitely a continuous process. So with this compensation and benefits, even with the Department of Budget and Management, it explored on how it will implement our concern when it comes to the disbursements of the special risk allowances, and we have the one COVID allowance. So the Department of Health will basically open a dialogue. I think by tomorrow we will have our open dialogue with various health sectors pertaining to these endeavors. And this is a great opportunity for us to be aware of some concerns and issues. So why we need to have the state of balance when it comes to these issues? Most of the nurses have been aware that the delay of the disbursement of the SRA and the OCA is only or solely a consideration of the concerns with the Department of Health. But during the time that the PNA have been represented during the health emergency allowance and the discussion of the implementing rules and regulation, there are also responsibilities that come out with the healthcare institutions. And mainly those healthcare institutions with pending liquidation reports have caused the delay of the disbursement po pala. So I think we need to have this balance also to awaken also the responsibilities of the healthcare institutions that they have also the accountability. So through this dialogue, the Department of Health and with the representation of the Philippine Nurses Association and other specialty organizations as well and institutions, we have been enlightened on how we will consider our response to our nurses, that we must also exert effort and also awaken our human resource departments in various healthcare institutions, that we have also accountability. So that's why with the collective efforts, we can resolve soon. So that's why by tomorrow, the Department of Health is inviting everyone po to have and to attend this dialogue. Number three, the positive working environment. Since the Philippine Nurses Association and other organizations have been a member of the International Council of Nurses, and the International Council of Nurses is also a member of the World Health Alliance. And one of the flagship program of the World Health Alliance is basically on the positive practice environment. So it involves also on how the nurses will be protected in their workplaces. So just a sharing, just recently we have encountered an issue with nurse Nelson Mantawil in Maguindanao. He was shot to death during his active duty, and her sister was injured also during the active duty. So we have called the attention through our position statement, and as well as we communicated also to the local government unit on how they will attend to this matter. So that's why we seek also the the assistance of the Department of Interior and local government. So it was acted upon, but we will continue to monitor and be vigilant on this perspective because it already concerned our security and safety in the workplace. So I think this is one that we will need to consider. So with the case of Nurse Nelson Mantawil in Maguindanao and with her sister who've been on duty and encountered these incidents. So I think this could also strengthen on how the healthcare institutions, the local government units will certainly attend on this concern. So number 4, concerns in the local and the national health issues is deployment and migration issues. Last night we had the meeting with the PR Board of Nursing and also with the POLO, with the Labor Attaché of the Washington, D.C. And they have opened up some concerns pertaining to our nurses who have been deployed in the United States. So that's why it is very important to have the labor education for our nurses here in the country before they will accept any opportunities abroad, because it is not just only on the perspective that you will accept these opportunities, then you will just work there, but there are legal imperatives to consider. With this perspective, we must also take into consideration these issues to protect also our nurses. For now, we can't control our nurses to be out of the country, and these are professional development opportunities as well. But for the meantime, we need to take into consideration our continuous monitoring and continuous vigilance on these endeavors to protect our nurses, even though they are working outside the country. To move forward, we have our proposal when it comes to how the institutional, local, and national, and even the global level will pursue. The first and the foremost is the enactment of our Philippine Nursing Act, because this will really consider on how we will start, on how we will establish to translate these policies to guidelines until it will be enacted and be implemented in the local government units. We have already passed this in the Congress. We have the House Bill 3298, and in the Senate, we have already the Senate Bill 1447. So we are seeking the support also of the appropriate agency to basically consider these endeavors on how the Filipino nurses will move forward in our situation at present. So our last Republic Act 9173 was already 20 years ago. And we need to move forward and be aligned and be responsive to the needs of the country, the region, and the growing global village. Number 2 is the strong representation of nurses in executive, legislative, and judicial offices. I know this has been an issue in some of the professional organizations if we will be apolitical or political. But realistically, we need to embrace this situation that most of the professional organizations, we need to consider representations so that from the grassroots up to the national level, we will move forward on how we will translate these proposals, these amendments, and will translate it and enact it into law. Number 3 is on how we will have the advanced practice nursing here in the country. This is part of the provision of our comprehensive nursing bill of the 2022. And number 4, bridging gaps between nursing education and practice. Because it is not just only in the clinical practice that we encounter concerns, but also in the nursing education. For now, we lack faculty members and clinical instructors in most of the schools of nursing. So how we can attend now to specifically yung concern to have rather to increase the enrollment, and yet we don't want to compromise the quality. So that's why there are also concerns when it comes to the nursing education. So we need to also have our attention to the nursing education sector. So that's why the Philippine Nurses Association, and this is with other the specialty organizations and interest groups, we have considered the PNA 10+1 Centennial Welfare Agenda. With the PNA 10+1 Centennial Agenda, the Philippine Nursing Centenary towards sustaining functional nursing workforce to face the global nursing shortage, the number 1 agenda is the inclusive implementation of nursing salary, of leveling of nurses' salary for both government and private sectors. Although we are implementing already the salary grade 15 to the government institutions. Now we are gearing towards on how we will resolve the problems of the private sectors. So that's why the comprehensive nursing bill will definitely establish on how we will put into the perspective of giving also attention to the welfare of the private sectors. Our intention for the meantime is to consider po if we had the salary grade put into with the government, then we could consider sana for the private sector so that it will open also opportunities. And I have talked to yesterday, I had a talk with Dr. De Grano on the PHABI. They're really now encountering a concern with the private hospitals. And this considered po basically on the salary. So hoping that this could also standardize and the implementation of the salary grade 15, although it was attended already for the nurse 2, but we also need to take to have the attention to standardize the nurse 3 and up salary scheme. So hoping this will open a discussion to the government and to the appropriate agency on the matter. Number 2, with the plantilla positions for nurses, actually this is for both education and health sectors. This is to support the standard ratio for quality nursing education and patient care management. Although it has been emphasized by the Department of Health that we do have already the HRH master plan for 2020-2040, and we really appreciated the effort. Hoping we could be continuously involved, and the plantilla positions actually will open opportunities for our nurses when it comes to the discharge of their responsibilities, even serving the public health. So number 3, no contractualization. I just want to say this, it's just so sad that there are some regions in the country that some of our nurses are still on the job orders and contract of service. So hoping we will have this attention to consider po yung status of the employment of our nurses, because this has been a battle cry of our nurses wherein where their employment status also had been considered as one of the major factors. That's why either in the private sector, even in the government sector, they consider the option of having their application abroad. So next po, we have the comprehensive and expanded health benefits. So this is an ongoing process, and we are very cooperative and supportive of the endeavors of the Department of Health, the DBM, and other healthcare agencies on this, so that it could consider po sana not just on the national level, kasi at present, the established benefits are on the perspective of the national level, but wanting to take in the concern of the attention is the local government units. Kasi this will consider din po on how the city mayors and the local government officials must also take into account na even the salary grade 15 is not being implemented in some of the LGUs. Number 5, for us to have a strong voice in our society, in the national and in the international level, representation of nurses in health boards. This has been a call for the Department of Interior and local government, since we do have the local government code, that nurses be a member of the LGU and national health policy, health groups, health boards from the provincial up to the city health offices. And we are also proposing in our comprehensive nursing bill the appointment of National Chief Nursing Officer. 6, we have the expanded role of nurses. This is to support the advanced practice nursing and to establish the career progression framework here in the country. So that to also consider that in our professional development here in the country, we will also expand the opportunities. Moreover, with the participation in the universal healthcare, this will expand on how our nurses will be skilled, will have the high confidence to serve the public. Next, we have the number 7 on the protected overseas market pertaining to the nurses, and this consider the strong regulation of protection of rights and welfare of OFW nurses. We have signed a memorandum of agreement with the Department of Labor and Employment, and we have been oriented on the various implementing guidelines, and we have been endorsed also to the appropriate agencies on how we will explore, including the welfare issues and concerns, not just only in the local, national, and the international level. And I know that in the number 9, we have the government scholarship for the nursing programs in the education. However, before we proceed with the scholarship, we had the positive practice environment, which had been considered to institutionalize holistic wellness programs across healthcare settings, including the GDAS. This includes specifically the rights or protection of rights on safety and security in the workplace, which I have mentioned the case of Nurse Nelson Mantawil and Nurse Nerissa Mantawil. With the government scholarship that we have in nursing, both for private and public health education institutions, so we have been aware that it has lifted already the moratorium. The next is to offer what is deserving for those prospective students to take this or to pursue in this program through the awareness campaign pertaining to the availability of the scholarship. Before, correct me if I'm wrong, during with the CHED, the nursing has not been part of the priority programs, but with our collective efforts to have this prioritized, it has been included by the Commission on Higher Education, and we are very happy po that this will consider din po as to have the strong campaign for it. Next, we have the 3-year Universal Healthcare Service. Service orientation. This is related to the return of service agreement. So we support also on how we will retain our nurses in the country. So that's why for those scholars or for those who have benefited from the scholarship, so we are proposing institutional return of service agreement to serve their own areas, not here, probably in the National Capital Region or in any areas, but it has been identified po yung GDAS, then we need to take into consideration on how we will respond to these concerns because most of the affected areas in the country are the GDAS and the other areas. Last but not the least, the +1. We have considered 10 plus 1 because this is the most important, the comprehensive nursing bill. So our call to translate this into the national policy, we must enact a law which is from the House Bill 3298 and from the Senate Bill 1447. So that's why my last slide have this newspaper that the president already knows our situation here in the country. And he even mentioned to us in the Philippine Nurses Association that he will consider this issues of the welfare of nurses to be the priority of the government and hoping the government, our president, Ferdinand Marcos Jr., to consider this enactment of the law so that this will translate into the national policies that will benefit our nurses. Thank you very much and good morning.
Thank you so much, Dean Melvin Miranda, for sharing the 10+1 agenda to benefit our nurses. And we are glad that we have the DOH with us and even the WHO hearing our concerns in the profession. So at this point, we would like again to inform everybody that we have again hundreds. We have around close to 200 participants joining us via Zoom, and we have around 50 plus joining us through Facebook Live. And they have again questions for our panelists, particularly asking on the measures that can be taken to address the plight of our healthcare workers. Now, for social media posting, we'd like to ask everyone, to use our official hashtag, for our national policy dialogue. So at this point, we would like to call on our last but not the least, presenter for our first panel discussion to share her insights on the challenges and proposed solutions in retaining this time our midwives in the workforce. Friends, join me in giving a big hand for the Executive Director of the Integrated Midwives Association of the Philippines, Patricia Gomez.
Thank you so much, Aaron, for that very kind introduction. If I may use this. Okay, so once again, thank you very much, sir, for that very kind introduction. A pleasant good morning to all of us. Good morning.
Good morning. Good morning.
Yeah, especially with our guest this morning, our OIC Secretary of the Department of Health, soon to be the Secretary, hopefully, and we're praying for that. And of course, Dr. Padilla a while ago, because I know Dr. Padilla because during the time of the preparatory stage of the NBS law, we're together, of course, in sharing it nationwide that they should pass, of course, together with the the senators, the congressmen, diba, lobbying with them to really pass the newborn screening law. So once again, thank you so much, of course, for the invitation, and I hope many, of course, has been said by our OIC Secretary of the Department of Health, and of course our nurses, because our nurses and the midwives in the field are really working together, and of course our leader in the field, of course, are the MHO, and that is under Dr. Kalimag, of course. So it's really a team, it's really a team when you say of public health supposed to be. And right now, we have two kinds, of course, of the midwives as well working. We have these public health midwives and we have these private midwives as well. No? But I will first be talking of the midwifery profession in the public health. And I will be talking first, of course, of the midwifery education right now. Midwifery education was introduced in the country in 1922 as a 6 months program just to supplant the hilot, or the traditional birth attendant in the field. So, but after maybe how many years, it was increased to 1 year, maybe because they saw the importance of the midwives in the field. Then after another maybe 2 or 5 years, they increase it again. Maybe in 1976, they increased it into 2-year program. And until now, we are in a 2-year program, but we have already the approved ladderized program in 2007 with our bachelor's in midwifery program. So what I'm telling you this is, the midwives, we know that the midwives are really the frontliners, no, in the field, especially when you say of GIDA. When you say of GIDA, we don't have, like for example, mentioned by Yusik Vergere a while ago, that in Batanes, no, Batanes, we have a lot maybe of midwives in Batanes, but maybe few doctors, because we know that our midwives are really in the far front. And when you say of, like for example, we produce, during our time, we produce about 7,000 midwives maybe a year. But right now, with these 261 schools of midwifery nationwide, we only produce about 1,000. When in fact, during our time, no, we were the board exam, two times, no, April and November. And during our time in April board exam, we have this 8,000, 7,000 to 8,000 midwives who took the board exam. But currently, you only have about 900, and maybe we cannot reach 1,000 per board exam. So which means there's really a decrease, of course, in the when you say of those students who will be taking the midwifery. And thanks God, as mentioned, of course, by by Asek Vergere a while ago regarding the scholarship. And right now, we are producing 300 scholars per year, of course, funded by the Department of Health. Up to the time that these students of ours will be taking the board exam, and fortunately, they're receiving more. That's the dilemma in the field, because they're receiving more. But they just graduated, they just passed the board exam, and they're receiving more salary than those in the plantilla position in the government in the rural areas. Yes, so there's really a problem, of course, in the field then as well. But of course, the beauty of this is you have to go on schooling for 2 years, and you have to serve the government for 4 years with a salary. So by the time you pass the board exam, you are very certain that you will be having this work already. So that's the beauty of it right now. And of course, thanks to the Department of Health again, because there's already a solution when you say of lacking the midwives and the field. But again, when you say of migration issue, well, I will be talking first of the impact, of course, of the COVID-19 when you say of it. So when you say of migration, maybe just a few midwives who wants to work also abroad. It's because our education is not comparable in almost different parts of the world, because in other countries, midwifery is a 6-year program after nursing. So here in the Philippines, it's a 2-year program after high school. So how can we work as midwives in other countries? Because education natin is not comparable, of course. 6 years sila after nursing, di ba? Dito naman, straight from high school, going into the midwifery program for only 2 years. So we're not really, but for midwives, Filipino midwives who will be working abroad in the Middle East, well, they can. they can work as midwife. Hindi man sila masyadong, I don't know, parang stricto when you say education, no? So especially in the hospital there, because I was able to visit, of course, some of the midwives also in the Middle East. So that's the dilemma. But I'm not saying that we will be producing, of course, a lot of midwives again then to work abroad. That's even though right now we are really proposing for a 4-year straight program. The reason why, because when you say of midwives in the field, when in fact, every time, Doktora, kaya nakapalagi din kami nagmi-meeting ni Asik Jerry, it's because I have really a lot of issue. Like, for example, in the central office, there's one person in charge of the program. In charge in family planning, in charge in MCH, maybe, no? And even in the provincial health office, or even in the DOH. But in the field, the midwife is the one in charge in all the programs. So with a 2-year preparation. So these are really some of the issues that we're really crying for so many years. And again, if the local executive will not say that you will be given a raise, or if the local executive says that you will stay for a job order for almost 10 years, diba? That's again the dilemma in the field, because when I went to one of the remote areas, even in Region 6, no, then I asked the midwives, what is your, your plantilla? Do you already in the plantilla? No, ma'am. Soon to retired ASEC, and still job order, receiving 6,000 a month. So sabi ko, mas mataas pa yung helper, di ba natin? But of course, again, working as, di ba, little doctors in the field, because they don't have doctors, especially as mentioned, of course, by Asik Jerry, especially in remote areas. So, again, those are some of the, issues, of course, when you say of public midwives. And again, the number of hours of duty, yun ang kagandahan siguro, the beauty of having right now a secretary, doktora na promote mo, ASEC, no? Our ASEC in the Department of Health, diba? That's the beauty, because she really rose from the rank, and she really know, diba, what's happening in the field. Being of course the she has the experience of really working as a municipal health officer. That's the beauty of it, because ideally it's really different from the reality. Yes, we want to have a ratio of the midwives, like for example, a midwife per 4,000 to 5,000 population. But unfortunately, we have these midwives working with a 60,000, 30,000 population. And you as a little doctor? Well, in fact, we have this outstanding midwife, no, in the PRC. And I scolded her because, ma'am, I'm sorry, I cannot attend because there's a stab wound. And you're the one suturing it. Yes, ma'am, it's because no doctor around. Lord, excuse me, then transfer it again to the hospital, because it's not your job to be suturing that stab wound. And nobody, ma'am, because I'm alone. So, well, I'm sorry, but I can, Asik Jerry knows about sometimes my being emotional, di ba? Emotional. So again, resignation maybe of health worker, yes, there are. For those really na soon to retire then during the COVID-19, yeah, that's right. We have a lot, of course, of midwives also who resigned. Ito naman sila ay soon to retire na rin. 1 year na lang in service, then they will be retiring. Of course, their family really are very protective of them. And of course, the children say, mag-retire ka na, mommy. Anyway, 1 year na lang yan. So, those maybe. But for those midwives who are still younger, they keep there are a lot of complaints maybe. But nobody resigns. I told them, ang dami-dami yung reklamo, hindi naman kayo nagre-resign. Di ba yun? Ma'am, kasi kawawa yung community. That's the beauty of it, di ba? Of the midwives really working in the field. Even though, sabi natin, they're working more than 8 hours a day, as mentioned, of course, by Asik Jerry, and Saturdays and Sundays, and even holidays without additional compensation. But I admire them for that na kahit na ganun pa man, di ba? Benefits ay kulang. Still, no, then the depression, no, the stress. When in fact, our organization is, of course, very affected, of course, with this COVID-19. And what we're doing, together, of course, with our friend from obstetrician group, from the pediatrician group, we have this free webinar for them for telecounseling, as mentioned earlier, no? Then some mga mental stress yung mga coping, mental problems during COVID-19. So we do have a free webinar, of course, every other week no, and for our midwives. Of course, for them, of course, to to combat, of course, some of these problems that they have, especially in the ground. No. So again, when you say the challenges, well, there's so many challenges actually. But go back to the education. That's the reason also that we're trying, or we have already submitted to the CHED to have a straight 4-year program. But, Doctora, it's a ladderized type. So for 1 year, maybe a BHW or a community health worker, almost the same with you in the UP, Doctora. But of course, we're being advised by CHED to really work on the ladderized program. So there's always an exit. After a year, you have to exit. Then you have to be given a certificate or a diploma of what you have finished in a year. And after 2 years, again. But of course, on the 3rd year, we have this internship already, Doctora. So internship for the 3rd year, and of course for the 4th year, it's really more of the research already. Because we lack research in the midwifery profession, because again, it's a 2-year program. And hopefully, the CHED will approve already our 4-year degree program, ladderized, and the board exam will be given after finishing, of course, the 4-year program. So, and hopefully, may nagsabi na pag 4-year na daw, ay maghahanap na kami ng mataas na sahod, we will be looking for a higher salary, we will be going abroad. So, I think if there's a chance, why not? But I think it's really more of what you call this, adding their skills, their knowledge to be working in the field as little doctors. So that's the reason why we have to increase the number of years naman of our education when you say, I mean of midwifery education. So, burnout, nandyan pa rin yan. But again, sabi ko nga, hindi naman sila nagre-resign. So, again, salary, as mentioned po by Melvin, no? The salary, the allowances, even if it is in the law. That's a question of mine before. Even if it's already in the law, Magna Carta, there's Magna Carta, there's local government, there's another UHC right now. But again, we are being asked also go back to education. We're being asked also by CHED and the DOH that we have to enhance. No, there's no problem when you say of PHE integration in the midwifery profession because we have already PHE 1, PHE 2, even during our 2-year program. So much with this 4-year degree program, we already added or enhanced the PHE course namin because of this UHC law. No, so for our midwives. So I think it's just an enhancement kasi nandyan na yan sa even before the UHC law, yung ating yung ating primary healthcare course natin, no? So again, the workload, nandyan naman yan, di ba? So, when in fact, if I may also, because right now, we're asking the support of one congressman, again, also as mentioned also by Melvin, na meron silang batas na inaayos. Right now, we are also propose some amendments to the law. Like, for example, sabi nga natin, on the education side, on the salary side, on the ratio side. So, napakadami. But anyway, and of course, the education, no, natin sinabi ko man kanina. When you say of permanent position, lifting of migrant health workers, wala naman kami masyado dito. And of course, sabi ko lang kanina, yung ating sinasabi natin na Magna Carta, I don't know, sabi ko nga, wala naman nakulong na di ba? Sorry, local executive na hindi naman nag-implement ng mga batas sa baba. So, yun ang problema maybe in the Philippines. There's a lot of good laws, but unfortunately, di ba, wala namang napaparusahan sa hindi nila pagpatupad ng batas. So, that's the problem. So, we have this also career progression, of course, for our midwives. Again, mandated by us, of course, by the PRC, that we have to have this career progression na for all professionals actually. So we are working on it also. And as mentioned by Secretary Jerry regarding the certification of those professionals who will go up the ladder. I want to be a professor, so I think the requirements are this. So I want to be a teacher and the requirements are that. So we're working also on that and hopefully to be approved already by the Professional Regulation Commission. No? So again, we have this private sector, if I may say again, no? We have private midwives who are already helping the government, as mentioned, of course, by Sir, regarding the SDN, or the Healthcare Providers Network. And we are encouraging, of course, our private midwives to be joining the SDN, or the Healthcare Providers Network. And the beauty of this is our report, di ba? We are encouraging our midwives to report to the public health sector, to the public health facility of their report. And of course, these private midwives are doing their job really of reporting their their services, or what services they're already given to the clients, to the public sector, and again, adding to the accomplishment of the public sector. So that's the beauty of it, that these private midwives are also doing that. Ang problema lang, if I may say again, Asek, regarding the training of these private midwives. There are a lot of trainings. When you put up a birthing clinic, there are a lot of trainings required again by the Department of Health. And it's so expensive. Bemong training is 34,000. Family planning is 7,000. IUD is another 7,000. So these private sector midwives are also the ones serving the community. Nadi-deload nga yung ating mga public sector midwives, di ba? But the training is so expensive. And it's not only for one training. There are a lot. Like for example, the basic life support training, ma'am. Before, it is every year. Why every year? If I'm fractured this year and I'm fractured again on the next year, different modalities or different type of ano. So right now, it is only every 2 years, but still, ma'am, every 2 years is so expensive. Diba? So expensive, and we're paying for that. The BEMOG training is about 25 to 34,000. So then these midwives will be the one, the private midwives will be the one to spend for their own training and open a birthing clinic. And yet, we are also helping the government when you say of our accomplishment. Because these private midwives are the one reporting also to the public sector. But anyway, I have a lot of naalam na ni Asik Jerry yung aking mga litania noon pa. Di ba? So again, the PhilHealth, Lord, excuse me. We have PhilHealth people around. But anyway, we keep on negotiating. We keep on talking to them, to the president, down to the regional directors of the PhilHealth, and even Dr. Gano as well, that help us. Because these midwives have a little capital. And here, this PhilHealth claims up to 2 million for one clinic. Lord, diba? And they have a little capital. Anong susunod nilang bibili na gamot, na mga gamit, diba, sa clinic? And they have their staff too. Diba? So I think I've already given this litany of mine to Asik Jerry for so long a time. And I hope, Asik, you will be the secretary again, but at least naintindihan natin lahat nangyayari. But anyway, so I think, sabi nga natin, crying for equal pay, equal benefits, di ba, mga ganon. But anyway, some of you here are also knowledgeable of what's really happening in the ground, especially with our public health worker, and me naman as private midwife. So I hope I've given a lot, di ba, of the problems, the issues, and hopefully the solutions, because actually, sabi ko nga, I have already talked to one congressman, and hopefully we can already amend some of the law. Because right now, ladies and gentlemen, we have a lot of work which is not already in the midwifery law. We go beyond the midwifery law because nobody will work in the field. Diba? They're given these services na hindi naman natin napag-aralan. Diba? So I hope, of course, our friend from the Department of Health and soon to be the Secretary, diba, will help us really improve, of course, these issues and challenges, of course, in the ground, especially for us midwives. And thank you very much for listening, and good morning once again.
Thank you, Pat, for bringing the energy into the room. Yeah, and indeed, we are honored to have with us the prime movers of our healthcare system. We have the DOH with us, the WHO, and other stakeholders, hearing again the plight of all our healthcare professionals in the country. So the question now, okay, what can be done, and how can policy bring about system changes to these pressing issues affecting our healthcare workers? Now, before we move on to our next part, which is again our open forum, I would like, by the way, to inform everyone that lunch will be served at 12:30 in the afternoon to give way to our open forum. At the same time, we also like to acknowledge various organizations, joining us online via Zoom and Facebook. We have the Filipino Nurses United. We have the Health Alliance for Democracy. We have the Alliance of Health Workers. We have Alyansa ng mga mag-aaral ng nursing ng Pilipinas. We have the Philippine Medical Students Association. And of course, we're also happy to have the DOH Facebook page watching us live through FB. So at this point, again, we would like to extend the invitation to our panelists to join us in front. May we call on again the representative from the World Health Organization to join us. Luis Torres, the Philippine Medical Association President, Dr. Kalimag. We have, of course, our OIC of the Department of Health, Maria Rosario Vergere. Dean Melvin Miranda of the Philippine Nurses Association. And of course, we'd like to call back Patricia Gomez of the Integrated Midwives Association of the Philippines for our open forum. So we are opening the floor both to our on-site and online participants in the National Policy Dialogue to share their questions to our panelists. We have a microphone, on the other side. And then I am reading through, our comments via Zoom and Facebook for their questions. So at this point, we would like to start off with asking our members of the on-site participants or the on-site guests to use the microphone for their questions. Do we have questions from the floor? Okay, maybe call on and recognize Dr. Lynn Lorenzo for the first question.
Just to start the discussions, and as everyone knows, HRH has really been close to my heart, working on it for decades. Dr. Rosette knows also that we have been in the trenches together. Okay, just a question. I don't know if this can be professional or total. Yes, we have production issues, but this is something that I think society has always been pushing, especially industry, the healthcare industry, that the Philippines does not have enough health workers. I'd like to ask everyone, on a national scale and on a global scale, is production really the problem? And so therefore our solutions for scholarships, even for masters and PhD programs, is that the solution? Or can we think about how we can use production solutions to actually stave off these short, medium, and long-term problems that we have? Second, is the environment of HRH management and development in the Philippines conducive to actually retaining our health workers meaningfully and effectively? Maybe you can talk about this in your professions, and also what is the trend globally. And I know retention at the national level is a very sticky issue, but maybe we can also ask our officer in charge, Dr. Bergeri, to say this. So production and retention, two very important proposed solutions. But the question is, how do we do this and who will be in charge? So anyone, please.
So I'll start and respond to Dr. Alino. So it's quite threatening that our professor and the expert in HRH is now questioning us. But so Dr. Alina, rest assured that we will give our very best to answer and get one in our grade. So first, if we talk about production, as you as our expert know, it would always have multitude of factors. for us to identify different solutions to these current problems in our healthcare workforce. It is not really just producing, but also finding the right mix of these different healthcare workers that we would need in different areas of our healthcare system. As I was saying a while ago, for our hospitals, for example, it is not really, of course, nurses would always be a problem in our hospitals, but also we need to also have that focus on our allied healthcare professionals. I was a director in our licensing office and also became an execom official for that, overseeing the different facilities and the standards of care. And one of the things that I have noted would be that we were really short. No, there was this shortage of rad techs, of what are these ancillary services that we have, also of med techs, also of specialists like radiologists in far-flung areas. So it is not really just nurses and doctors in general, but we are really very short on different professions across different services that we offer to people. So if we say it's just production, it is not, because even if we produce so much nurses as what has happened before, it did not solve the issues in our healthcare workforce. We need to have the right mix. That's why I was telling a while ago, we need to have a complete assessment of the different needs of the population based on the facilities inventory. For example, we may say, and this is based from experience again, that in one part in Visayas, they were lacking with pathologists. So I tried to investigate why. And there was this practice among societies that there was this seniority, that only the seniors would have these areas and more junior specialists would only have these areas. So we were looking at results of laboratories being signed by a pathologist who was from this part of Visayas, and then finding out that the results of the pathological reports also maybe in northern Luzon, we were also finding his signature. So this is quite, parang you won't even think of it na it's going to still happen in this age and time, but it's happening. So we need to have the right mix. We need to have that inventory. It is not just producing a lot, but producing rationally. That is one. We have different needs across different sectors, especially now that we are having these multi-specialty centers. We need to be able to think rationally and be strategic in how we are going to address this problem. The second would be how to retain healthcare workers with this current management that we have. I think it would always be also not just looking at how we manage our healthcare workers and looking at the governance side of it, but also looking at the demand factors, where really the demand for Filipino healthcare professionals is really high across the globe. It is not just because we are very skilled, but also we are very compassionate. And Ma'am Lynn knows about that, and all the ambassadors going here are all praises for our healthcare workers. Pero at the back of my mind, I'm saying, gusto mo lang uli kunin yung mga healthcare workers. That's why you're telling me that you admire them and they're very passionate. But, kidding aside, for us to retain our healthcare workers, it's not just a matter of giving them monetary incentives. It is also a matter of giving them that security, giving them that confidence that they are safe in their workplaces, giving them that confidence that they are valued and recognized across the spectrum of our professions and healthcare professionals. So hearing a while ago our doctors, our nurses and midwives, us from the Department of Health, gave us additional inputs on how we can better address the issues currently. Like what Ma'am Pat was saying a while ago, I was already discussing with Chancellor Padilla that, the 2 years course of midwives, and then you go abroad and you cannot practice your profession because we are subpar with other countries. So this should be part of our directions, that our healthcare cadres should be at par with other professions. Dapat pag pumunta tayo sa ibang bansa, katulad ng mga doktor, kumukuha pa ng mga NLEX, mga NCLEX and all of those things. When in fact, if we do it here, we go to other countries, we are at par with them, there is this equivalency, then we don't need to go through that. So the direction should be that we should all be striving toward that part where our curriculum here in the country, our standards here in the country for education would be at par also with other countries. We're not saying it's going to happen overnight, but it should happen maybe in this next 10 years that we are all still alive and working together. So I think that's all that I'm going to say. I'll pass it on to the others, Dr. Arlene.
Okay. I think it's going to happen sooner than later because we are now at the Professional Regulation Commission looking into career progression and specialization pathway. And then accreditation of, instead of just accrediting units for continuing professional development. And with that, with all the specialties actually submitting our alignment matrix for the specialties, then we will be able to see how we are aligned for level 6, 7, and 8. So we're hoping that it will be better now, because of the career progression pathways. But even so, I'd like to comment regarding the specialty hospitals in the provinces. While we are saying that they're already there, in some areas, for example, cardio, the heart center is already looking into all of those. However, there's still instances, for example, I think that access to healthcare is also a problem. Because if, for example, if we have one specialty hospital, kunyari, in northern Mindanao, in Cagayan de Oro, we have to understand that the next place in northern Mindanao is, for example, Bukidnon, is 2 hours away. So if you have a cardio patient where time is of the essence, he or she, the patient, might have a hard time also getting the cardio specialization in northern Mindanao, in Cagayan de Oro. Hingoog Medina is also 2 hours away. Camiguin is 1 hour away by boat, and then 2 hours away. Kasi Camiguin to Hingoog Medina is 1 hour by boat, and then 2 hours from Hingoog Medina again to Cagayan de Oro. So perhaps those are also issues that we have to address regarding accessibility. So I think that is also a problem that we have to look into. So it's not just production. I would like to ask Nelvin here. I remembered in 2009, there were about 95,000 nurses who took the licensure exam. Perhaps we need data as to how many of them actually came back and became nurses. Kasi only 35,000, I think, of them passed that board exams. So, what happened, for example, to the rest? Did they come back and took the exams again? And are they now nurses in the field? May nag-ask ng question, sorry.
Yes, ma'am. Thank you for that wonderful question. Actually, with the 95,000 that had taken the nurse licensure examination, so our concern really is to track yung tracking of our nurses where they are working now. Kasi with the data that has been provided by the HHRD related to the practice, we still have the data ng mga nurses who are not practicing in the field. So they have tracked those numbers. So I think yun din yung isa sa mga like consideration po namin for we need to identify kasi during the time before, ang naging problem naman natin before, mataas yung supply and then the concern is the open positions for them. So that's why they have reverted into the other field. So that's why may mga in just recent years po when it opened again yung nurse licensure examination for them, dun sila nag-take just recently. So yun yung nagiging trend ngayon, ma'am. So ngayon lang sila bumabalik and basically because of yung there are many positions that are being open to our market.
Yeah, thank you so much, Dean Melvin and Dr. Kalimag. We have Luis from WHO who would like to comment on the question of Dr. Lorenzo.
The original question.
Yes, please.
We like also non-original questions also, no problem. Now, let me reflect on the production. I think, and a bit bring the international experience. It's true, there is a shortage problem. There is no doubt there is a shortage problem, but I think we stop too close. I think we have to, and on the shortage, we have to put together also the discussion of maldistribution and productivity. We at WHO, we are doing analysis on performance on health systems, and definitely in places where shortage is claimed, which we are not challenging, we also see very low productivities. So I think that from a health authority's point of view, we have to bring the two things together. Second point I would like to make is one point that I made in my presentation. There is many of the master plans and strategic plans that member states develop are based on, I would say, the old paradigm of let's plan, produce, allocate in the public system. That's the main assumption of the delivery model for fixing HRH issues. But the reality is not that. I mentioned it. Many of the key decisions that affects HRH performance outcomes are because are driven by market forces. And this is where I put the example of PhilHealth and allocations, IRA, and see whether the incentives are playing these roles. And then the last point is which cadres, no? As I said before, it takes 10 years to start to fix the problems of HRH. So we are now starting to fix, if we do a good job, we will fix the 2030 challenges. The 2022, we are too late to fix, or not at the scale that we would like. Of course, there is things that we can do for today, but not at the scale of what we are looking for. But one of the points is which cadres we want. And let me be a bit provocative, is if we want a sustainable system in 10 years' time, we need to shift care outside hospitals. And we need to shift care outside of a specialist hands. The specialists are very important. We need them, but we need them to do a specialist job. And we need hospitals to do hospital job. And that means that we need to shift a lot of care outside hospitals, and we need different cadres. Then, when we're talking of production of what? No? And developed countries that have taken the route of paying much more the specialists vis-a-vis family doctors, you end up in a model where the user are doing hospital hubbing. And actually, it's not an issue of affordability of the system or sustainable of the system, which it is also. But my point here is that the patient do not get a good deal. Even if can afford to do the hospital hubbing and jumping from super specialist to super specialist. So from a UHC in the mindset and from a systems point of view, what are the type of cadres that we want to avoid the shortage in 2030? And that's a bit, I agree, shortage, yes, production, we need to be worried. We have to do the planning, but let's look at the final goal of how the system that we would like to pursue for the challenge that we will have in 10 years' time.
Thank you, Luis. We have another question for the members of the panel to address, coming from Facebook, and this is with regards to how can we address the problem of red tagging of our healthcare workers, because according to them, one of the reasons why they are reluctant to go into rural areas and engage in primary care is the fear of being red tagged. So what can we do in the context of policy to address this issue? I think Dr. Vergeire can best respond to the question. And perhaps we could hear also from a global perspective from Luis with regards to the same issue.
Yes. First, the department, through our policies, always ensures the protection and safety of all of our healthcare workers. Now, in the different settings that we have in the different areas of the country, there would be this propensity for this kind of situations where red tagging would happen because of some forms of a partnership or a work that is being done by our healthcare workers. In order for us to prevent such incidents or to better assure our healthcare workers of this, I think it would be through the partnership and the collaboration that we do with all sectors concerned that we can ensure the safety of our healthcare workers. I have not been able to really discuss this yet with our officials. But of course, we know the tragedy of the doctor who was red tagged, brought to another area and then brought here again just because they worked with the marginalized sector of that area. So we'll need to enact something or discuss something, of course, not just with the Department of Health, but also with other sectors, so that we can ensure the protection and safety. As what I have said, the department cannot prevent actually this red tagging. But what we can do is to ensure the protection and the safety of our healthcare workers and to ensure that there would be policies to prevent the effects of this red tagging to all of our healthcare workers. Like, would there be additional benefits? Would there be this benefit of working with other agencies so that we can facilitate the needs of our red tagged healthcare workers? But unfortunately, for now, I do not have the answer if we can stop the red tagging or not, because I think it's more of not just the health sector's concern, but the entire nation's concern.
To be honest, I'm thinking still my answer. First, I need to understand what red tagging means. I didn't. Well, let me think my answer. Well, that's important. And actually, in overall policy making, is to have a good understanding of the political economy, no? So who are the stakeholders and how are they perceived, no? And for example, in my own country right now, not probably not because they are linked to a particular insurgent group, not because the insurgent group, but they are being. There is a conflict between the political ruling of a region and health workers, because and they are being brought into they are being labeled as supporters of left-wing parties. and this really disrupts there is a strikes right now going on, and they both groups trying to build a narrative of destroying the health systems. So for one is you are cutting the money for health, so you are starving of funds the system, and the other is you are left wing, that you want to put me out of my chair, and that's why you are doing strikes and you are not collaborating, and this is not helpful. So yes, this for example in Myanmar after the coup d'état of 2001, the most prominent supporters of the civil disobedience movement were the health workers. And actually 90% of health workers stopped working in the initial 3 months after the coup d'etat as a protest against the military rulers. So yes, there is realities where health workers are being brought into the political arena, and also because of activism of their own, this situation happens, and there is little solution beyond a constructive dialogue and beyond reprioritizing the what are the goals. And just a bit to finish here, Myanmar, when we were working as WHO and as a UN agency, we stopped working with the military rule. We have to create a safeguard saying for essential services and COVID response, we can work with the military services. So we need a bit this dialogue and explicit positioning to deal with that. Thank you.
Thank you so much. We have another question with regards, I think, concerns everyone on how can we work together to ensure that salary implementation and other benefits are standardized across public and private institutions. The question again is, how can we work together to ensure salary implementation and other benefits are standardized across public and private institutions?
I will start with that question and respond to that. As I've said a while ago, we already submitted this proposal, and it's a bill already wherein it has been sponsored by some of our legislators. The salary standardization between the public and the private. So we all know that this is really a huge problem, and it causes external and internal migration because we know that for the public healthcare workers, the salaries from the public sector is much higher than the private sector salary. So aside from the external migration where our healthcare workers goes abroad, there is also internal migration for which our healthcare workers migrates from the private to the public. That's why of late, the private sector hospitals are getting angry with the public. They are saying that because we give higher salaries to the public healthcare workers, it is our fault that their healthcare workers are leaving them. So ideally, when we have gone through the different reforms we have done in PhilHealth, one of the basic objectives why we implemented the case rate system was to have this bundled payment where healthcare workers, the fees of our healthcare workers are part of that. And second, whatever income that our facilities will gain through these PhilHealth mechanisms, that they will be able to include into their funds to roll out and be able to hire more workers or maybe increase the salaries of our healthcare workers. Unfortunately, it's not happening, and unfortunately, of course, there are still a lot of weaknesses in our PhilHealth care system. So right now, when we proposed for this, of course, there would be advantages and disadvantages to this. That's why this is just still a proposal, and this has to be thoroughly discussed with all sectors. Because if we look at the, how do you say that, Luis, in economics? When we look at the market, if we impose that there would be the standardized salaries between the public and the private, we are going to disenfranchise the lower income facilities or the lower facilities where they cannot afford to have this kind of standardized salaries. We have the higher level facilities who can afford, but these lower level facilities cannot. So there has to be some way where there are safeguards and there would be some form of exemptions. And this is what we need to all work with. But I think this is the first step for all of us, that there is this proposal already, and now this opens the door for all of us to discuss, that for all of us to be able to input and be able to arrive at that agreement or the final draft of this bill where everybody will benefit.
Thank you so much. May we hear also from our professional organization standardizing across all health workers?
That will be good news if it happens. If it happens, yes, because I agree with the internal migration. Because people on the ground, they will say, why don't you take a residency training in the government hospital where the pay is higher? No? But that will put the private hospitals into a disadvantaged position. And the PHAPI will not be very happy about it to the Philippine Private Hospital Association of the Philippines, because they'll be losing, the manpower that they have. Even the residents in training will be moving from the private to the public hospitals. I think that's the answer, no? Rationalizing the and or standardizing the salaries across private and public hospitals.
Okay, I think Luis from WHO would also like to comment. Yeah, go ahead, Luis. And then after this, we have Dean Miranda commenting on the question.
Okay, quick comment. Okay, what are the policy options to allow this to happen? No, we want to. The question is whether align public and private sector benefits for workers. Okay, there is the minimum salary, which will be, it's a regulatory tool that the government can do, but has the limitations that OIC Bergeri was saying. You know, you can put a minimum, but then the small hospitals, the ones that with a small size, might struggle to reach that. And then you will be able to set the minimum, but not probably to match, which is a different thing, which is what the question is about. The second thing is to use the financing option, which is good field health, basically increasing field health, or the single purchaser of the Philippines payment, make sure that that can address that. And for example, to use field health payments to address some of the issues on equity. For example, Batanes has little volume, and to secure these services that are minimum that, and they don't need to send it to Baguio, can we pay this extra for keeping and retaining there, including the private sector? So you could use the leverage of field health payments to address some of these issues. But we are again we are going to step on the same rock, or to meet the same wall, which is we are a big part of the system is ruled by the market forces. We cannot tell an owner of the private hospital, you have to pay more your doctors. You can't. So you can put incentives, you can play the regulation card, but we have to acknowledge that what are the rules of the game. Over.
Thank you, Luis. Go ahead, Melvin.
Thank you. probably my response is pertaining to our proactive legislators, not just only for the nurses, but all to the all healthcare workers. Wherein probably our legislators will need to support and revisit the existing laws of the professions, basically to identify the gaps and identify basically the specific solution in the future so that it will be translated into the implementing rules and regulation. Probably kasi if these bills will be enacted, it will allocate kasi din yung discussion on the financing. So I think on this perspective, if these bills will be enacted, and it's a good news that we've heard about it, that there are proposed bills, then it will translate now yung alignment. And the alignment will consider na po on the perspective that it will involve the appropriate agencies, including the grassroots, involving also the local government units on how they will respond to this. Kasi there are gaps probably in this situation now that we have the existing law, but the problem is the implementation in the grassroots. So I think this could be aligned, and with this framework, I think call for our legislators to support the bills or any proposed amendments to existing laws of the professions. Thank you very much.
Pat, go ahead.
Yeah, if I may add also, I'm also a victim of this. I think it needs to be studied because I have my birthing clinic before, and I trained my midwife, completes a training, family planning, MCH, and everything, and I only pay her how much. And when this government RHU opened of course, an opportunity for them to work, of course, they have to resign from my clinic, and I have to close my clinic because I don't have any midwife already. But she has a lot of training already, and the RHU may be so happy because they don't need to train this particular midwife of mine because she has the full of training. And I think I'm happy din naman because she was promoted after 6 months of working as what you call this, it's the regular siya, of course, after 6 months. So I'm happy also. My clinic was closed. But anyway, yes, it's hard, of course, because we have our own respective laws. Diba? So I just really don't know how we are going to marry, of course, the proposal of the salary standardization law, because you have your law, we have our law, and I think it's professional group have their law, and they started this salary grade, etc., etc. So I just really know how we're going to marry, of course, with this proposal, of course, of the Department of Health. And I think I'm very happy, as mentioned, of course, by Secretary a while ago, regarding the right mix of professionals especially in the RHU with this universal healthcare, and we are praying. Because we midwives will be very happy. Because we midwives work in the field as obstetrician, nutritionist, dietitian, pediatrician as well. So I think we would be very happy if there are really a lot of health workers who will be helping us in those in the RHU especially, if this universal healthcare will really be implemented. It's a law already, but I think the full implementation of it will be very happy. Thank you so much.
Thank you, Pat. We'd like to ask the panelists for a quick comment regarding supporting the mental health of our healthcare workers during this time of the pandemic. Specifically, there's a question on, how can we increase the PHIC or the PhilHealth coverage for mental health for our frontline healthcare workers? Dr. Vergere?
Yes, actually this is good news for our healthcare workers because during the last board meeting in PhilHealth, I've already instructed that PhilHealth facilitate the mental health package, especially for the Filipino people, and of course kasama dun yung healthcare workers natin. So soon we will be having this mental health care package whereby services will be covered through our PhilHealth mechanisms. Second, how do we improve our mental health services for our healthcare workers, and of course, mental health well-being of our healthcare workers. So during this time of the pandemic, again, good experience for all of us because we've seen the need for mental health services for our healthcare workers. We saw how, all types of emotions during this time of the pandemic, and even us working in non-health facilities like us from the DOH or maybe sila Chancellor Padilla, we were feeling the stress and konting-konti lang siguro na, just a little prick, you'd cry already. That's our state, before. And luckily, I think most of us got resilient and confident, and we're all braver right now. But still, it is very important. That's why we had been rolling out this MPHSS across the different facilities that we have. During the time of the pandemic, we've instructed our hospitals to have these regular sessions with our healthcare workers, especially those in quarantine. Do you know what's the life of a quarantined individual inside a big facility where you cannot see anybody, but you can hear voices and people beside your rooms? That's really something, and you stay there for 14 days before. So that is something that we have all gone through, and this has served as a lesson. And rest assured that we are intensifying our mental health services and program. As I've said, I've just been in National Center for Mental Health yesterday, and I've been to one of the international meetings 3 weeks ago for mental health. And this is the time of, this is the opportune time for all of us to start working and including and highlighting the mental health well-being of each and everybody, especially our healthcare workers. So, meron po tayong programa, package of PhilHealth is forthcoming, and our services in the different facilities we are intensifying.
Thank you very much.
We welcome that development. Yeah, go ahead po, Doc.
For the PMA, the Philippine Psychiatric Association is always there ready to help. So, especially now, not just a pandemic, but because of all the disasters going on, not just for our healthcare professionals, but also for our kababayans, no, who are undergoing all the stress and anxiety brought about by floods and typhoons and earthquakes all over the Philippines. So that's all. Ready to help.
We strongly support also if this could be institutionalized as well. And we in the professional organizations could be your arm from the DOH to implement also this to the grassroots and to the healthcare settings as well in all levels. Thank you very much.
Yeah, we're in support of that kasi actually sabi nga natin, even not our family, di ba? During this COVID-19, each one of us has its own fear, di ba? So I think it's not only the health worker, but I think it's the whole family. But when we say of giving information, good information to our health worker, and they can relay the message, of course, to their family as well. So thank you so much.
Yeah, thank you so much. May we also hear, we have another one about the one COVID allowance. So, I think we have been bombarded with questions online and even in our regional consultations about the one COVID allowance, and they would like to hear from the Department of Health. Dr. Vergere?
I had been waiting for this question. I thought it was the very first question, but I guess our host is very gracious. So para medyo we can have that kind of smooth and that he tried to place these questions towards the last. But anyway, first, our health emergency allowance. This is part of the law, and we are mandated to provide this to all of our healthcare workers. But hopefully, and we request also our healthcare workers to understand that we from the Department of Health only receives the budget from other agencies as well. We fight for our budget so that we can provide the benefits because we know that our healthcare workers deserves this kind of allowance because of the COVID pandemic. What we have issued out in the recent month, we were released, there was this 11 billion that was released for our health emergency allowance. So we need to differentiate between these terms because a lot of our healthcare workers would often expect that when we release money, they would already get even those that are retroactively those retroactive payments that are accorded to you or a part of the law pero hindi pa nabibigay. So when they receive their allowance and they find na kulang, sasabihin nila bakit kulang, hindi pa binigay, so on and so forth. So let us try to explain the process. The process would be that if we release money, nag-release ang DBM ng funds, we immediately download it to our regional offices. Now, the amount that we download to our regional offices would be based on the completed requirements coming from our facilities also. So there's a list for every regional office with those who have completed the requirements. No? So we all know there are, sabi kanina ni Sir, hindi lang yung gobyerno, meron din tayong obligasyon. And that is right because we follow COA rules. So we cannot just release money without any evidence that you are a part of the list of healthcare workers and you had been receiving it for the number of months. So kapag na-release na po natin sa regional office, ang regional office now will be calling each facility or informing them, oh, money is here, submit your requirements or your completed list. Unfortunately, there is also this rule in COA that our regional office cannot download further money to a healthcare institution if they have not liquidated the previous amount that has been provided to them. And we understand fully, many, especially those smaller facilities, hindi po nila naiintindihan kasi ang proseso ng gobyerno, so kulang-kulang lagi ang requirements for these liquidation documents. And we are tirelessly helping them, guiding them para makakumpleto, pero hindi talaga tayo nakakakumpleto pa ng binibigyan. So, nevertheless, what I'm saying would be, yun pong binabang 11 billion, nakapagbigay na po tayo, most of those who have received this were just being paid for their January to March of 2022. So, we are still waiting for, again, the release of DBM for the additional funds for the 6 months back. 66 billion. The 66 billion would include also the amount of money for this year until December 2022 plus the retroactive payment from July to December of 2021. So, excuse me. Again, let me explain and reiterate. We act immediately as soon as we get money from DBM. Every time that there are these timelines that we need to fulfill, kasi halimbawa March na kailangan na natin magbigay for April, nagsasubmit po tayo agad sa DBM para makakapag-release. But you also have to understand DBM because DBM also with their very limited fiscal space ngayon, humahanap po talaga sila ng pondo para mabigay din talaga kasi alam naman namin obligasyon ng gobyerno ito para sa inyong lahat. So rest assured that government is doing our part in trying to facilitate all of these monies na sa inyo po talaga yan. Just give us the leeway because sometimes processes in government really are very tedious, especially documentary requirements. And that's why sometimes, really and most often time, maraming delays. But ibibigay po namin sa inyo as soon as we receive the money.
Thank you po, Dr. Vergere. Yes,
Very
Patricia?
short, Asad. Rejoinder lang. Actually kasi some of the midwives wrote me a letter. Taxable? Oo, kasi nagtaka sila na they received that much only. So ako naman, I cannot explain it. Thank you.
Yes, every benefit that we get, even as from the central government, central office, are taxable. So kami, pag nakaka-receive tayo, notwithstanding itong mga heya, no? So meron ho tayo Magna Carta, di ba? Yeah. Taxable ho lahat yan. Ang exempted lang sa taxes natin, yung bonuses, because there was a law specifically that was issued for that. Kaya non-taxable yung bonus natin. Pero the rest, lahat po din po kami, ganun. Tinatax talaga lahat ng benepisyo.
Yeah. And we have one last question live from our audience. Ma'am Rosales from EMAP. Go ahead.
Good afternoon, everyone. In relation po to the retention and mobilization of the healthcare workers in the Philippines, it was mentioned a while ago that there are leadership development for nurses, and just recently there is a leadership training also for public midwives. Is it possible for the private practicing midwives like us to have the same training to also help the government when it comes to the global problem like this, the pandemic, during the pandemic?
Yes, ma'am. I think that's a very good question because now we move on to that part where the programs previously implemented just for the public sector will now eventually be open to the private sector as well. It is not just salaries that we are trying to standardize. We would want a standardized opportunity for both public and the private sector healthcare workers. Not just that, but also a standardized competency across the public and the private sector. So yes, ma'am, we are planning for that already. It is part on the table and being discussed, and we will be offering it to the private sector as well.
Thank you so much. And that wraps up again our open forum, and we would like to extend our heartfelt gratitude to our panelists for joining us and going beyond the allotted time for our open forum. A big round of applause, okay, for our panelists from the WHO, the DOH, and our professional groups. So indeed, our health workers are one in calling upon our prime movers, decision makers, and the entire Filipino community to work with us in making better working conditions for healthcare workers a reality. Because we believe that with better working conditions, it will lead to better healthcare and for improving health outcomes of the Filipino people. So friends, a round of applause for everybody for a fruitful and engaging session this morning. So at this point, we would like to inform the rest of the on-site participants that we will have our roundtable discussion starting at 1:30 this afternoon, and our groupings are flashed on the screen. So we have three roundtable discussion, and we will be joined by our moderators. Please refer to the list on the screen, and may we also invite the members of the organizers to please come in front. For a photo opportunity with the members of our panel, this morning. So, may we request again Dr. Vergere, Luis, to stay for a minute for the photo opportunity together with the members of the organizing team. May we invite, of course, Professor Dr. Carmencita Bedria, our beloved Chancellor, to join the photo opportunity. Dean, Erwin, calling Erwin. Ivan. Erwin. Again, the members of the organizing committee, join us. I think.
One more photo, sorry.
Chancellor, one more daw po.
One more. Okay. Go for everyone, please. Okay. Here, 3, 2, 1. Okay, thank you. One more. Okay.
Thank you so much again, Dr. Vergere, Luis, Dr. Kalimag, Melvin, Pat, for joining us this morning. Thank you so much. We're honored to have you. Thank you for staying on the session. you so much. We were really honored. Thank you. Stay healthy. Good job. Our roundtable discussion will start at 1:30 in the afternoon. We hope everybody will enjoy their lunch. Thank you.